longer a CCT level skill. We expect all paramedics to have competency in vents. Notice I said competency. That means you know how to use it on the call. On the transfer side, and yes, the 911 side. It's a standing order set in New Hampshire, this mechanical ventilation. I'll say this. It is a standing order set in the 911 system in the state of New Hampshire to use a vent at the EMT basic level. Ladies and gentlemen, are there any EMT basics in the room? This is in your scope of practice. Did you follow that? Now I have your attention. Let's start
quick.
What's that?
Told them to leave quick.
Let's start with. Are we on?
Yeah, we're on now.
Do you want to learn?
We're on, we're recording.
Good.
We're good. I'm still waiting for people to jump in, but I'll get them from my phone as we go.
All right. Let's start with something we know. When did this state allow paramedics CPAP?
I don't know. 15 years ago?
Yeah. Are we on board with that? Yeah. Now I'm going to blow your mind. I'm going to blow your mind. I'm going to blow your mind. Ladies and gentlemen, in the room, who has had CPAP their entire career? There's only 4 people in the room that remember a time before CPAP. It has been your entire career. And now it's at EMT basic level. Are we on board with that? So when you come out of basic school, you get taught how to use continuous positive airway pressure. And I don't perseverate, I don't perseverate, I don't perseverate, I don't perseverate. Why do I repeat what I said? I never asked a rhetorical question, by the way.
To hammer it in.
Yeah. Yeah, and if you expect a monologue today, you're wrong. We have to have a dialogue. Because at the end of the day, the expectation is you guys know how to use ventilators. Good. Good. What do the letters CPAP stand for?
Continuous positive airway pressure.
Fabulous. Good. What does it do? I like it, right? The textbook might use a different definition, right? But at the end of the day, it blows air in the lungs. Fair?
Yeah.
For what patients get CPAP? Yeah, I like it.
Technically, all of us. Because we all sitting here right now have peak of 5 because of our vocal cords.
There's always one. The man's not wrong. Right now, sitting here in this room, let's take it the next step, ladies and gentlemen. What hanging down a dangly thing, piece of anatomy, keeps CPAP in? Epiglottis. Now, in days of old, when necks were bold, we were taught that epiglottis sits on top of the openings and then chooses food one way and air the other way, right?
Correct.
At this point in time, what we need to realize is the epiglottis is the top of the balloon knot. And when we take the balloon knot out of the way, the lungs collapse. We lose reserve tidal volume. We lose PEEP. We lose EPAP. It goes flat. And every time you go to the emerge, and the respiratory therapist, excuse me, I'm being recorded, the respiratory therapist decides to bag them up, then you can hear words like, we got to bag them up. We need a lung recruitment maneuver. We got to fill those lungs up. We need to increase the A to A gradient. Why is that? Because anytime I do this, I take the balloon knot out of the way. And you lose PEEP. Straight hint number 1. If you want your patients to oxygenate better, put a PEEP valve on your BVM.
We have them, doesn't mean everybody uses them. Yeah. But we have them, which surprised me, honestly.
Yeah, I think Jason's doing a good job pushing good medicine. Yeah. We'll talk about it.
Let me tell you about an email I had once.
All right,
Go ahead.
moving on. There are no surprises in this room. Straight hit number 1, don't lose your recruitment. And the number 1 way we lose recruitment is with intubation. You see how that happens? And I use the word intubation. By that I mean king tube, combi tube, LMA, EOA, PTL, pharyngeal lumen, surgical airway, Shiley's rotary. You right? When you bypass that, you lose that and lungs go flat. Please stop that. And there are a few times you're going to hear my words, my tongue slip back and forth between terminology. I just used two terms. What are the two terms I just used? Yeah. And what do I accomplish with?
Skills.
Specific what skills? Take it the next step. You're not wrong. What physiological tool? Yeah. And when I intubate, I need PEEP. And you will hear me swatch the words PEEP and CPAP back and forth. Because essentially they're the same thing. CPAP, push air in, right? PEEP, keep air in. But if they don't have enough air, we increase our PEEP so we can push more air in. So what's a standard PEEP number? 5. Somebody would say 4 to 6 in this room, but we start mechanically at people 5, right? What's the standard CPAP starting number? Now in this state, if they're sick, like we walk into the apartment, we hear the bubbling fish tank bubble, 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 and we know how our next 20 minutes is going to go, right? Because there's no fish tank in the room, that's the patient. We start with 10 CPAP sometimes. Everybody on board with that? But let's start with normal numbers first. Fair? Let's go with normal. In a moment, we'll describe bad. Badness. What is PEEP? What does the letter stand for?
Positive and expiratory pressure.
Fabulous. What do the letters CPAP stand for?
Continuous positive airway pressure.
Right. Here's the critical thinking point. And yes, ladies and germs, we're going to think critically all day. I am not just going to show up and throw. I need your brains to work. What do the letters EPAP stand for? End positive expiratory pressure, or end positive airway pressure. What's a normal EPAP? 5. What does EPAP do? Sir, what does EPAP do? Say the same thing. It blows air in. What's the difference between PEEP and CPAP and EPAP? Nothing. EPAP is a standing order set in the state of New Hampshire at the EMT basic level. You guys have been using DPAP all of your career. There are only 3 people in the room that remember a time before EPAP. Yes. Did you follow that? So if you show up at the emergency room and the respiratory therapist looks at you and says, hey, their PEEP was 5, but it took their PEEP to 10. Where's the EPAP?
EPAP 5.
If their CPAP was at 5 and the respiratory therapist went their CPAP to 10, where is their EPAP? 10. It's the same thing. There's no magic. It's the same thing. So what does EPAP do? Nice. Now let's take this to the next step. If you're running a paramedic down in Lawrence, those Cambodian gangs, yes, the number 1 language spoken down there is Khmer. English is 3, by the way. Random tangent. They like to take the machetes and slit open lungs and put the lungs on the outside of their chest. I don't know what kind of message that sends, but I'm sure it said, I love you, my friends. Here's a trick question. This is not a fair question. This is a set up question. Everybody on board with that? I'm 100% going to set you up. What's the number 1 substance in those lungs, in all lungs?
Nitrogen.
Nope. Nope, that's number 3. I told you it's a set up question, not a fair question.
Steel.
Nope, steel. That's number 1. That's not. Your son. Yeah. Steel, right? And everybody doesn't want to say air. And you're not wrong because air is number 2. Yeah. And then the math doesn't add up. But let me describe it conceptually. Let's move it on conceptually. It's not mathematically or anatomically correct, but it makes sense to say there's twice as much blood as there is air. Because for every 1 alveoli, we have an artery and a vein. You follow that? Then we go from the alveolus to the artery. That's called an A to A gradient. And our average A to A gradient is 3 to 4 centimeters of water. And I'm never going to use the word centimeters again because it makes me sound pretentious. So just assume that all of these numbers are centimeters of water. Fair? The A to A gradient is 3 to 4. Why does my EPAP have to be 5? To push the right way. What if we have an A to A gradient that's 7? What is that? We need to be at least 8, right? Or 10. Follow that? Excellent. Good.
All right, so how do we assume to know an increase in that grading? Because we don't have all the fancy tools.
Right in the basement. We're gonna go to the first floor in a minute.
Cool.
I'm playing checkers. This man's playing chess. He's 3 steps ahead. That's exactly where we're going. Can you imagine telling breath by breath, moment by moment, the exactly peak resistance in somebody's chest?
Man,
Yeah. Wow. Let's take this the next step, ladies and gentlemen, to continue to make my point. What do the letters P? And I don't perseverate. I repeat myself because it's important. What do the letters P stand for? Thank you. What do the letters PIP stand for? Peak inspiratory pressure, or positive inspiratory pressure. And a lot of textbooks use different words for the same thing. So I'm going to try to introduce you to all of those words. Peak inspiratory pressure or positive inspiratory pressure, depending on what textbook you're reading. And I'm going to put this out in the very beginning. Don't forget these numbers. A normal peak inspiratory pressure is 20 to 30 centimeters of water. What is a normal peak inspiratory pressure?
20 to 30.
Yeah. Now, I did work with some hillbillies down in West Virginia, and they coal mine down, pickaxes, shovels, dynamite, right? And they still deal with black lung disease. Yeah, true story. The hillbillies down there, their names were Bubba, Bubba, and Bubba, and they had great moonshine. I learned a lot from these hillbillies down in West Virginia, honestly. But if you have black lung disease, do you need a little bit of PEEP, or do you need a little bit of positive end expiratory pressure, or a lot? To get across the soot, right? Everybody on board with that? It makes sense. What's this redneck, hillbilly, not a redneck, he's a hillbilly. Right? Started explaining, like, you need the pressures there. It makes sense. So when I say 20 to 30, that's by the textbook. In the face of black lung disease, or COVID, or cystic fibrosis, sometimes you will see higher peak inspiratory pressures on your patients. There. So if you're doing an interfacility transport from bad hospital to good hospital, or community hospital to large not community hospital, whatever we call it, and their peak inspiratory pressures are at 31 or 32, that's because they held on to too long and we should ship them out a few days ago. But in the transport realm, we get stuck with bad numbers sometimes. Everybody on board with that? And if you have a peak of 40, is that high? Yeah, you better have an explanation of why you're there. And sometimes there's a good explanation, right? Black lung disease. Okay, thank you. Ready?
Don't get that up.
No, but we get
COVID pneumonia.
COVID pneumonia. See, I'm laying a platform. You still
Sorry.
You're there. See, this is where we're going. I'm going to COVID pneumonia, right? So let's talk about what makes sense first. Let's talk about a neonate patient. Neonate coming 500 grams. Dad's wedding ring fits on the arm. Sad stories. 30 weeks preemie.
And I'm not taking it in this truck.
A little bit of peak inspiratory pressure or a lot of peak inspiratory pressure? A little. Everybody on board with that? Because we don't want to pop some lungs like this. Fair? Let's talk about Pickwickian syndrome. And if you do not know what Pickwickian syndrome is, Einstein said never memorize what you can Google. So please pull out your phone and look up Pickwickian syndrome.
It's pink.
And if you ask Siri, Siri will say, picking your nose, what? So it's pick, P-I-C-K, Pickwick.
Not about difficulty breathing when laying on your back.
It is. Fat people laying flat. You see Pickwickian patients every day. By the way, what is the first treatment a Pickwickian patient gets? Thank you.
Plastic bag over there.
Hey, you want to hear an interesting way to have a form of that without it being Pickwickian? When you have your gallbladder out, having damage your diaphragm.
Oh, yeah.
I don't like flat anymore.
Right, because you can't move the muscle.
Now, in the last 4 years, intercostals have built up better
Sure.
to compensate.
Right.
But that first
But you were
year,
retaining like you never knew.
that first year, I could not lay flat for 5 seconds without becoming acutely short of breath.
Wow. Yeah. We'll talk about that for work with that muscle.
Yeah.
Cool. Pickwickian syndrome patient. Oh, by the way, if you do not sit patients up, the vent will alarm. You follow that? Yeah. Yeah, ding, ding, ding. Yeah. the number one hint, and I have many hints for you, if you want to avoid the vent alarming, don't forget good BLS.
You're talking your high pressure, right?
If you want to avoid low pressure, we'll go to a whole bunch of them. If you want to avoid, the number one reason is bad BLS. Fabulous. The other thing I'm going to tell you right now is those are not vent broken alarms. Those are patient care alarms. So if the vent alarms, your first thought should be treat your patient, not your monitor. Follow that? Thank you for stopping. If the alarm goes off, that is a patient care alarm, not a vent broken alarm. So your first thought should be treat your patient, not your monitor. If you first hear an alarm and you're like, how do I change the vent to stop that alarm? You've done something wrong. Treat your patient, not your monitor. Fabulous. Pick Wikian syndrome patients. High peak inspiratory pressures or low peak inspiratory pressures? Before you start. Yeah, everybody on board with that? We have to move that body habitus. Perfect. Perfect. What's a normal peak inspiratory pressure? Fabulous. Good. Here's the critical thinking. Remember I asked you guys to think critically? A flail chest. 2 more ribs, 2 more places are the sternum. Is that a fair definition of a flail? Good. Okay. Question. A lot of pip or a little bit of pip?
A lot.
Why do you say that?
You've got to displace the weighted plate that's falling on the ball.
Sure, the ribs that are there. Then why did they say it's a critical thinking question?
I think maybe injury to the lung underneath if I put too much pressure.
If I put too much pressure in, those bones grind together and I get crepitus. And then I'm at 50 of fentanyl, 100 of fentanyl, 200, 300, 400 of fentanyl. All of a sudden I'm wondering why he's not breathing and there's still a pain response. What's going on? Well, I'm causing that pain by grinding the bones together. You follow that? Iatrogenic. Then why did they say it's a trick question?
Such a patient file really going on.
Yeah, if I don't lift it enough, then he's hypoxic. Right? If I don't give him enough ventilation, he's hypoxic and he dies. If I give him too much, I grind those bones together, and that's rude. Right? So what's the appropriate peak inspiratory pressure, ladies and gentlemen? Thank you.
Whatever he needs to.
Can you imagine targeted breath by breath, the exact pressure in lungs? If they have too much, you back it up. If they don't have enough, you turn it up. Moment by moment, breath by breath. I have a goal, an objective, a doorknob objective. When the class is over, you guys stand up and you go to the doorknob. You turn the doorknob to leave my class. My objectives, I want you to know that that ventilator is safer than a BVN and faster than a BVN. Please don't use a BVN anymore.
So this thing's actually going to replace BVN.
Oh,
Not this.
Yeah.
because I've been a paramedic longer than a ventilator, I'm going to tell you I want 100 tools in the toolbox. I want a demand valve, I want a ventilator, I want it all.
We've been fighting to get a vent on every medic truck here. And we had vice presidents telling us, oh yeah, we'll get one for all the trucks. And we've had other people going, no, we're not spending them. Hold it. Clinical leadership. We don't need a vent. We can bag them just like we always have. It's just as good. I fucking quote you that. Brother, you need to speak to.
So,
Bullshit.
what I will tell you,
So back to my question.
what I will tell you is it is a good paint, it is a bad painter that comes with brush. I want good medicine with whatever tool I have in my hand.
I get that.
Yeah, whatever tool I get, I have an A game. Yeah, good at, I don't care if I got a bellows. I'm gonna do it well with bellows. Remember I talked about a peat valve and a BVM?
My phone just came off. I've been fired.
Fabulous.
You're Kevin. You may leave now.
Fabulous. I want an
Say
A
action.
game with whatever.
Yeah. I do have a picture of a bellows being used ventilated by someone from the American Heart Association.
Or an anesthesia bag. You with me? An anesthesia bags have peat valves on them. And when they're inflated, you squeeze just for the peat valve. I don't care what tool you do. I care that good medicine matters. And let's take it the next step. For years, we've been told ventilate for chest rise. With Pickwickian syndrome patients, you will never see their chest rise. And with neonates, by the time their chest rises, the ones that pop up. Right? So target pressures. Yeah. Target pressures with your bag valve mask as well. Just pay tight attention to it. Do bag valve masks have thermometers on? Yes, they do.
They're supposed to be on the pediatric and neonates.
Yeah.
They're not on the adults.
So you can accomplish the same task with whatever tool you have in your toolbox. What is it?
One
Normal
more word
people.
about fucking BBM.
You gonna bring a knife to a gun show?
Probably not.
So let's start. Speaking of knives to gun shows, 1, 2, 3, 4. My name's Eric. What did you say your name was again?
What was that?
What was your name again?
My name is Flo.
Flo.
Yes. Nice to meet you as well. I apologize.
5, 6, 7, 8, 9, 10, 11 people in the room. I'm going to go with 100%. I'm going to be presumptive and judgmental. This is not a judgment-free zone. This is a judgment zone. 100% of people in this room have a handgun at home.
They thought I'm like me.
Right. All right. 99% of people have a gun at home.
You
No?
have a 12 gauge.
That qualifies.
That's
That's
not a handgun. That's a two-hand gun.
The lady's not wrong. Thank you. You're correct. Correct.
We only have one person who does not have a firearm. He does not like.
Let's go back for a minute.
I've been asking, no one wants to take me out.
Oh, I'll take it. Okay.
Not one of mine has killed anybody. I'm pretty certain of it. Yes.
Mine hasn't either.
Guns have triggers. Duh. Vents have triggers. All of them have triggers on them. Other ventilators call them flow triggers, or sensitivity triggers, or flow rates, flow triggers, sensitivity triggers, E-flow triggers. The Z vent calls it a pressure trigger, or a P trigger. The Z vent calls it a P or a pressure trigger. Now, our factory preset on P trigger, on pressure trigger, is -2 centimeters of water. What's our factory preset on trigger? -2. It's the amount below P. So if my P's at 5 and has a trigger of -2, they have to draw 3 water columns to get there. Perfect. Now let's talk about New Hampshire. In Polk County, Florida, they don't have to worry about those roads are smooth. Up here, nobody has any idea what a frosty is. I start running frosties, like what? Frosties, potholes, speed bumps, snow, black ice. Every one of those things affects ventilator rates. So if your ventilator is set at 10
rates, or does it set the readings that it's supposed to receive?
both, and it reads too high, it'll trigger the rate. So you're connecting the, you're there. You're there. Our factory preset is, right, let's make it a heavy or hard pull trigger. Pull, 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 breathe, 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 the vent should surprise you, right? Fabulous. Our heavy, hard to pull trigger is -6 centimeters of water. What is our heavy or hard to pull trigger?
-6.
So if you're driving down the road, down the 16 and the 95, and you're hitting potholes or speed bumps, or you're going to Maine, how often do you guys go to Maine, man?
3 times a day.
Really? That's where I trained. I trained up there with Dr. Tony Thomas. And you hit these speed bumps, you hit these potholes, and the rate that you want your patient breathing is 10 breaths per 1 minute. That's a good rate, yeah?
Yeah.
And then you hit 32 potholes, and you wonder why your respiratory rate's 40 and your vent is alarming at you. Right? Take your trigger and go to -6, please. Then the vent will not breathe for every environmental noise.
So comparing that to the LTV,
Yeah,
that was the sensitivity to 10.
Correct.
That's,
Yeah,
okay.
yeah, we call it a pressure trigger, they call it a sensitivity
All
trigger.
right, okay, cool. Because, yeah, we were putting that to 10 on, doing CPR.
Yeah.
And it wouldn't trigger it at all.
They
So
don't-
same, different phrase, same thing. Okay.
Correct, correct, different
Thank you.
terminology. Yeah, thank you for that.
So we're keeping the HG70s as well.
Why?
For the 911 trucks, because they've been buying for us.
So you want to discuss the difference between the P-trig for that versus the Zoll? Because that runs 0.8.
No, don't, it's 10, because you're here for Zoll.
You are, but we're also going to be running two different vents.
You also asked if people wanted to versus if people wanted to.
Yeah.
Would you
Yeah.
like,
I will.
just so people aren't
I will.
confused?
Let's go to 10. Their 10 is a heavy draw or hard to pull trigger. And by the way, to be fair, I have used the Newport HG70 much more, or the Newport HG50 much more than I've used the Z. I have both experience with both. So if you have a heavy draw trigger and you drive down the road, whatever other vent calls it the heavy draw, which is their heavy side or their flow triggers, right? Or their sensitivity. So I'm gonna see the heavy side of that, when you hit potholes or speed bumps, it will not trigger another breath. In the aeromedical world in transport, if you lift to elevation in a non-pressurized cabin, those pressure differentials sometimes will trigger a vent. Fair?
That might be one of the things we run into, especially with our HT70, and also when we use their 1200. We're using their vent settings in a quiet, dark ICU that's not fucking moving.
We won't go to the second floor.
Yeah, you're spending too much time in the basement.
Moving on.
I know, we do
Let's go.
run into these
Let's go
alarms.
directly there. Let's
You
go
know?
directly there, right here, right now. Let's do it.
Yeah.
I'm not afraid. In the ICU or in the emerge, in EC, that mattress is 1 foot thick. In a non-moving environment with the lights down, 32 pillows and 54 of those blankets. And I'm like, ah. And they get a dram of Versed every 3 days. And they're wonderfully situated. We put it in the back of them with an ambulance. And the mattress is 1 inch thick on a steel frame, riding backwards to speed up bumps and potholes. And here's, this is a joke, not a real question, but it has some validity to it. What is the half-life? And let me pick a random airline. What's the half-life of rock uranium? 45.
45.
30 minutes away from where you gotta go.
There's the wisdom. Right? Half the transport. How long is it from here to Main Med right now? Okay. So 45 minutes into that trip at Main Med, what town is that? What road is that halfway there?
Standish.
45 minutes from.
Standish?
I say stand.
All right, let's go Standish, right?
Yeah.
If you're starting to approach Standish and you know your medication is getting soft and you're at 0, -6 on a pressure trigger or heavy pressure trigger, and that patient starts to wake up, they will not be able to breathe on the vent. That vent trigger is too stinking hard and blocks them out. Because the trigger is too stinking heavy to pull, right?
Mhm.
They won't be able to get breath. They won't suffocate because the vent will be breathing for them, but they will feel like they're suffocating, and that's rude. So if you're gonna have a trigger of -6, or a heavy trigger, whatever vent we're talking about, your patient has to have a RASS score of -5, or a Glasgow coma scale of 3. And we accomplish that medically. Everybody on board with that? And then you have to know before you go, what's the half-life of Versed? Oh, here's a street tint. If you're going to paramedic school, stop listening to what I'm saying, because you'll fail your paramedic test. But if you need a flat-on solid street tint, the half-life of the medication is often the same as the repeat dose. Right? And that doesn't always hold true. That's a really sloppy way to say it. Everybody on board with that? And my paramedic professor would be really angry at me if you say stuff like that. But what's the half-life of Versed?
5 to 10.
Okay, so if I had IV push, and normally we don't push drugs on transfers, fair? But if just from this, all right, we'll do the math.
Ideally, no.
All right, but let's go there. If I have a hour and a half trip and my med gives me 10 minutes, How many doses of Versed do you need?
2 nights for 13 milligrams.
You gotta know before you go. You have to do the math before you leave. All IV pumps have timers. Look at that timer. If you're showing a Scanish and that patient's starting to wake up and your trigger is -6, that's your fault. If you're gonna put your trigger at -6 and have a quiet vent, you just accepted the responsibility of paralyzing your patient.
And sedating them.
And checkers and you need to go calm down, shut up, and go to sleep.
Oh, everything, don't
Right? You need paralysis, you need sedative, and you need analgesic. And if you have a question about that, the early 1980s show The Serpent in the Rainbow. Get a date, whatever your date is for you, right? Get some popcorn and soda pop and watch The Serpent in the Rainbow movie, and it will change how you do mechanical ventilation. 1980s affects all of it, right? Accept it. It is what it is. The Serpent in the Rainbow, great movie. But there are many, many studies out there that show when you increase stimulus, you have to increase sedation. If you decrease stimulus, you can decrease sedation. There are many studies on this. This is a well-documented fact. New England Journal of Medicine describes it. Just dial that into any medical workbook and billions of studies. The more you increase stimulus, the more you have to increase sedation. Everybody on board with that? What is the advantage of propofol? If we call it propofol or method of amnesia or diprovan, whatever I call it. What's the
juice?
What's that?
Jackson juice.
Jackson juice. Or what's the advantage of it? Why do they like it in the emerge? It is. You turn it off to wake up, right? And now let's imagine us driving down the highway and we shake the hell out of the patient. What happens to the patient? They wake up and we have a high pressure alarm. And then you try to figure out how to fix the vent. Did you get that? I can't. Am I being recorded?
Yeah, you're being recorded.
Okay. Follow your local protocol. Yeah, you got to double your propofol dose. If they're at 50, go to 100. If you're going to transport with propofol is a sedative. It's not paralytic. It's not analgesic. You got to double. No. More pro before you leave. Get the order to make it happen.
You bring extra bottles?
So the problem is that up there, they don't see that hour-and-a-half ride. They don't care about that hour-and-a-half ride. And we don't always get access to the docs to say, hey, we need to do this and this is why. He's been fine on that.
Yeah, he has.
Which
in
is
a
the
non-moving
problem.
environment with a mattress that's 1 foot thick, right? In 52. Oh, by the way, what's the temperature outside today, ladies and gentlemen?
It's warm.
16 this morning.
16?
Yeah, really.
21. It's warm. Yeah. Stage 4 hypothermia. Did you follow that?
Yeah.
Yeah. Stage 4 hypothermia. Please keep your patient. What's normal body temp? Make sure your patient's 98 degrees.
Starting at the 40 degree stretcher.
Yeah. You see that? Not just with a
Frozen equipment.
bath blanket and a Johnny. That patient has to be 100 degrees warm. And I'm not being facetious when I put that number out there. I mean, literally, a measured temperature at 100 degrees. If not, they're going to shiver. And if they shiver, they increase their base metabolic rate and they're going to need your medication faster. So if you want your patient to be sedated chemically longer with a count, yes, notice I'm still talking about pressure trigger of -6. Right? I love me some -6, but I just owned the responsibility for to have that patient at 100 degrees. You follow that? Keep them warm, please. Crank up the ambulance, please. Use a silver blanket. Use a wool blanket. Use a sleeping bag, please. 100 degrees. 40% of the base metabolic rate work, right? ATP, glycogenesis, sugar, all that stuff. 40% of that job comes from the diaphragm. If you make your diaphragm to work harder, your base metabolic rate goes up and you eat faster.
Good work.
You need more oxygen.
Any more oxygen, and you need more warmth, you need more sugar, or you can keep them warm. BLS matters. Perfect. Perfect. And yes, there is hey, Jason. there is a direct parallel between temperature and treatment and heat in medication. Perfect. Good. Let's do some more critical thinking while I'm on trigger. Notice I'm still talking about trigger, right? Let's talk, and I'm going to suggest this is true with all lab values. I'm just going to pick one lab value to make the story, but you need to consider all lab values. What is an H&H? What is it? Thank you. What is it? Yeah, percentage comparison. Right. That's a good way to put it. And again, I don't think that's the textbook answer, but it's perfect. I like it. Nice. I like it. What is a normal hemoglobin and hematocrit?
Male or female?
Good. Let's go with male.
15, 35.
All right, let's go with 15 because it's an easy number. Everyone on board with that? Okay. And you're doing a trip from local hospital to big hospital, and their H&H was 10. Is that terribly low? Well, it's not healthy, but this is why we're doing the trip. Everybody on board with that?
Not transfusible.
Right, but we still need to be aware of it, right? That would be a good value I need to hear from the nurse or the sending staff, right? The next question you have to ask, ladies and gentlemen, is their H&H just 10? I'm concerned, but they need to be not here. They need to be there on my radar. I'm going to do the trip. Everyone on board with that? Your next question has to be, how long has that been? Because if their H&H went from 15 to 10 over 2 days, and you have an hour and a half trip, I'm okay with that. If their H&H went from 15 to 10 over 30 minutes, and I have an hour and a half trip, what's my predicted H&H? Everybody on board with that? You have to ask time. You have to know before you go. You have to
The
do
problem
math.
I see sometimes is these labs that I'm getting are 6 hours old or greater. They're not current labs.
You're not wrong. Now we own the responsibility to dig a little deeper. What's the underlying etiology? Where are they bleeding from? Is it a GI bleed that's pacted? Did they cauterize it? Are they hemophiliac and they've been that way forever? You have to find that question out. Because if you don't, then we're halfway there. The patient will decompensate and you wonder why. I'm going to make a strong statement, but I'm a big fan of this. It is all predictable. If you ask the right questions at the right time, 100% of patient care alarms are 100% predictable. You follow that? Because if you don't have their H&H figured out over time, and you're halfway there and their SATs start to drop, well, you shouldn't be surprised by that. Right? Fabulous. We're still talking about trigger. Keep them warm. Keep them sedated. Stimulus equals sedation. What is our factory preset on trigger? What's a hard or heavy pull trigger?
6.
Excellent. Good. Oh, by the way,
Fucking paying attention, man.
the man's not wrong. He's there. He's got it.
Yeah, I am. I'm just a face it. Leave me alone.
Man's not wrong. He's there. Oh, by the way, when they do not move patients in the emergency room, they don't set triggers. You follow that? In a non-motion environment, the sending facility often does not measure this or change the sensitivity of the patient. It has to be something on your radar, because I can tell you a secret. Can I tell you a secret? We move patients. Do that or not.
I was in the wrong room. I thought I was in the room.
Yeah, right?
Well, that's halfway to the truck.
Fucking right.
Right? It is.
Yeah.
It's
Right there. Just don't take a left to the truck, go straight ahead, you're in the freezer.
So you're saying before we leave the facility, we should drop our trigger set?
And induce your sedation. And have that conversation with the doctor. As respiratory patients. If not, then that's an alarm. Fabulous. And you realize, how do I fix the vent? Let's go to the other side of the story. The other side of the coin and do a trigger of this. What's our factory preset, by the way? Excellent. Let's go to -0.5 for the easy or softer hair trigger. Bump it, pulse, great for speech. Boom, 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 right? Right, like a bump stock.
So this starts at -2, but you can decrease that You can make it easier.
Yeah.
Okay.
Yeah.
I didn't know if that was
Right.
like 0 on the LTV is like 0.
Yeah.
So this -2 is a 0. on
Correct,
that.
correct.
Okay.
It's the amount below peak. So if our peak was at 5, they go to -2, have to move 3 centimeters. If they're at 5 and we're going to -0.5, they can move.
So it's quite minuscule.
Yeah.
The preset was at 3.
What's that?
I thought the preset was 3, the pressure trigger was at 3.
-2.
-2, not negative.
So you look at that tube and you're gonna take a breath.
Yeah, but let's talk about this practically. Like, why would we ever be there? If we had a patient that should have called 911 last night, but we show up at the house and we move into the room and we hear the bubbling fish tank, and then we realize there's no fish tank. The man is bubbling.
Right.
And he's in full failure. And he should have called last night, but he's tired. His sternocleidomastoids mastoids are heavy. His chest isn't lifting. He's just tired. And we're gonna intubate him, right?
Yeah.
But hopefully we won't have to. If you trigger, go to 0.5, then any little movement of those lungs.
You'll pull a big breath.
You'll pull a good breath and the vent will help. Did you follow that?
So you're doing this on CPAP or BiPAP? as
Or
opposed to
any patient
just-
that's breathing.
Right, well,
Yeah, SNAD. Yeah. So if the patient is actively breathing and moving air, we like that trigger at 0.5. What's the disadvantage of -0.5? Yeah, roll artifact. What's the advantage of it? Yeah. What's the disadvantage of -6? What's the advantage of -6?
They're unconscious.
Yeah, right?
It's just not gonna go. They're not bitching.
Yeah. And what I cannot tell you is where the right place is. It starts at -2 and bumpy roads, you want to go up a little bit. So maybe you go to 3 or 4. Right? If they're really tugging and doing hard, to go to 0.5 with your masked patients. Right? The problem with mechanical ventilation is there's no protocol to be written. You have to EMT. You have to assess your patients. You have to look at your patient, treat your patient like a mom.
What does the scale go to? Is it -6 on highest it goes to?
It is. That's the top.
And it goes down to what, 0?
Nope. 0.5.
0.5 is the lowest.
Negative 0.5. Yeah. And so negative 0.5, -1, -1.5, -2, -2.5. And later I'll put myself on a vent, and then you can mess with me, change the trigger, watch my eyeballs come out, and then maybe it'll come up, and you'll see it. It'll be evident. Good. Good. What's the advantage of intubation, by the way?
Secure the airway.
Yeah, I can open that airway, can lift the chest. Excellent.
airway or breathing.
Right, right. But I lose PEEP. Everybody on board with that? So their lungs collapse. So there's a risk and challenge to all of medicine. There's a risk benefit. Fabulous. And for years, we've been told mechanical ventilators. Everybody inhale for me, please. Inhale. We have these crazy things in our lungs called stretch receptors or hair and growth receptors that keep our lungs from popping like zits. And when we do this fancy paramedic stuff, or this, whatever we're doing, we bypass those stretch receptors, which is why everybody's afraid of mechanical ventilation, right? Because we're told we can pop lungs like this. Can I give you a secret? We've been doing years with a bag metal mask on every patient. We just went to wear it, right? So when I'm done with this conversation, you should feel safer and faster with a ventilator. Excellent. What is pressure trigger or P-trig? You guys tell me. I don't perseverate. I review. What is pressure trigger?
What's required for them to draw a breath?
Perfect. And what's our factory preset?
-6.
Right. And when we go to -6, what's the advantage of that?
Less road artifact.
Yeah.
Breath.
What responsibility do I own?
Keeping them sedated.
I own that responsibility now, right? Yeah, we've locked out that patient. And to be fair, I'm okay with that. I just need to accept the responsibility of keeping their lungs full. Write this down, guys and gal. Pressure is married to volume. Pressure is in love with volume. They will not separate. So if your pressure goes up, what goes up? If your pressure goes down, what goes down? Excellent. Excellent. Good. Let's talk about tidal volume. Ladies and gentlemen, EMT basic level curriculum in the state of New Hampshire. Oh, I have not talked a lot about ALS. You get that? The majority of them talking about EMT basic stuff. Right? We went on some tangents about sedation and paralysis, and that's medic stuff. Fair. Keeping your patient warm, basic stuff. 100 degrees, targeted temperature, 100 degrees.
You can't get the back of our ambulances that way.
Then you got to bring some blankets, some hot packs, heated IVs.
We do have these heated blankets, you know, the hand warmers?
Yeah, you pop the corners.
47 of them.
Yeah,
We have those.
yeah. Please, on every transfer.
Well, they can't do- Let's not do on grandma going to the nursing home.
You get right.
Jesus, we had to sell a truck
Every method transfer.
Fabulous.
or every critical transfer.
Yes.
Yeah. What was it? Tidal volume. EMT basic level question. What is it? Define it for me, please.
Say it again?
What is tidal volume?
It's not air that goes into the lungs during breath.
Love it. Love it. That's it. That's all we're looking for here, right? Let's not make zebras out of horses.
Volume of the tide.
Right. Of air.
Chest rise.
Chest rise. In theory, they're the same. They aren't always. Right? Tidal volume and chest rise should correlate, but they don't. EMT basic level question. What is a tidal volume number?
500 milliliters.
Yeah, 500 milliliters. A better way to look at that, ladies and gentlemen, is 4 to 6 mLs per kilogram. 500 is a great place to start, but that is only a start.
That's a lot for a lot.
No, I was on the kilogram part. Better definition kilogram for these folks. As far as what kilogram or what.
I'm getting there.
Okay, well,
Let's make fun of me.
you stopped. So I was
Yeah,
asking.
no. And
No, I'm through with you.
I have a very important point to make. Remember, pressure is married to volume, right? Fabulous. Here's well, you don't have to be nice. I think we know each other well enough that you do not have to be kind to me. How much do I weigh, ladies and gentlemen?
64.
220, exactly. Yeah, so how many kilograms is that? Fabulous. And if I need 4 to 6 mLs of tidal volume per kilogram, how much do I get?
4 to 600.
400.
Yeah, 600? Everyone have one?
Your ideal weight's about 175.
So
Yes.
if pressure is varied to volume, then I put my volume at 500. Right, and where's my pressure go? Yeah, which is why we're more afraid of not what they do weigh, but they should weigh, their ideal body weight. I am 6 feet tall. Dr. Zoll has been very good to me since I've been working for Zoll. I have put some happiness on, and I do weigh 220 now. I should weigh,
175.
let's do the math, 175, 4 to 6 mLs per kilogram. How much should I get, guys?
So 82 kilos roughly.
32.
350, 400.
350, 400. If you use my body weight as it is, you double my volume. If you double my volume, what goes up?
Pressure goes.
Pressure, and you damage my lungs. You see why we use ideal body weight? Please, please. And there are height charts out there.
Yeah,
There are
they're
wingspan charts.
gonna say these charts are,
All under the radial charts. Do me a favor and stop right now. If you're doing an intracitic transport from Ramstein to George Washington, please check and do the math for the volume every time.
So it's not done by weight, it's done by height? Is that essentially?
Ideal body weight, what they should be, yeah.
Just want to make sure I'm following that.
Yeah, you are. Lungs don't have fat,
Right.
so if you have a lung.
Not used to it.
Yeah, PH80. Yeah, tempting, yeah. So, and that 1-year-old child that drinks Pepsi through a baby bottle, and he's 100 kilograms, he doesn't have lungs that size. So please,
So monster energy drink for the babies.
I
So
just
is
did
it the
some-
same for peds?
yes, and midgets.
So I just did some math. 180 pounds, 82 kilos, 4 to 6 per kilo is 328 to 492.
Yeah.
And we're dumping 500 into everybody.
Right, you see how, and if we know that pressure is married to volume, if I dump too much volume, I dump too much pressure. And we are causing atelectasis.
So are you better off to err on the side of caution on that and go lower?
I'll answer that question.
So it's 3/3.
Hold on, I'm playing checkers, you're playing chess. Let's stay in the first floor.
God, it's not just me.
Yeah.
So put the whole socks on, we'll run with it.
Let's do it, guys. Let's go there. The reason I go slowly,
Same thing.
the reason I go slowly,
You're used to the people from West Virginia.
in the face of BPM, in the face of COVID, everybody bought fence. Everybody on board with that? So my company made a killing. I did all right. But now the sales guys taught it to people that can't even spell BPM. I'm a so the other reason is because I want you to understand the concepts. I can give you the facts, knowledge-based education, and then you get a critical patient for understanding. Knowledge, application, synthesis. Let me teach at the synthesis level so you can learn the why. So when you're on the corner bumming hooker with an unknown medical and it doesn't go well, you can know how to fix it. Fair? FiO2. To your point, sir, what is FiO2? EMT basic level question. Fabulous. What is it?
The percentage of the air molecules we're breathing in that are
Yeah, fabulous. And in room air, it's 21%. By the way, in Gloucester on the North Shore, the measured FiO2 is higher as it comes off the ocean in room air. And if you go to Oakland, California, their measured room air FiO2 in atmospheric is lower, and that's not about elevation.
California sucks the life out of you.
Maybe, I don't know. I don't know.
Care about all those wildfires too.
Yeah, a whole bunch of reasons, right? A whole bunch of reasons. What is pulse oximetry?
Percentage of surface area that hemoglobin covered.
Yeah,
By something.
right.
Right.
Yeah, right. Everybody up over that?
I didn't say what this is.
Yeah. He left that up purposely.
Yeah.
But God forbid, use our shield and cable all the time.
And now let's presume, I know there's 8 seats on the bus. I know that, right? But let's only go with 4 red blood cells and 2 oxygen molecules. What's my SpO2? Fabulous, good. Right, in this simple diagram, right? What's my SpO2? 100. 4 and 8 oxygen molecules. What's my SpO2?
4 and 8.
No, if I have 4 red blood cells that are all done, and then I have 4 unbound oxygen molecules.
It's 100.
It's 100, right? I did not show that simple model well with my fingers.
No.
It's 100.
Yeah.
I did, you're right.
You get one.
Get up one, yeah. But don't leave your shoes on, because we don't want you to do it with your toes.
Don't tempt him to use
Yeah,
an 11th digit.
I can count to 21. I don't have bread, so I'm going to use green blood cells. Are you on board with that? What's my SpO2?
100.
Fabulous. What's my SpO2? 100. Everybody on board with that? This is bound. What's my PaO2? High.
Yeah.
High. Let's go with simple high. Everybody on board with that? PaO2 is both bound and unbound. Right? But in the state of New Hampshire, what is, and AHA guidelines recommends we maintain SpO2 at what number? 94 to 98, not above 100. What's my SpO2? What's my PaO2? 100. Follow that? No free radicals. What's a noxic encephalopathy, ladies and gentlemen?
Brain death for life loss.
Game hemorrhage. What's the onset of game hemorrhage? 4 to 6, irreversible at 10. Everybody, yeah, 35, depending on what textbook you read. Yeah.
If you started out healthy at minute 0.
You're not wrong, right, not from the insult, to the insult.
Right,
Yeah.
Which none of our patients are healthy at the moment they arrest.
And if we get too many unbound free radicals, we cause the anoxic cell, because that doesn't just hang out. That attaches to other gas in there, nitrogen, becomes nitrous oxide, profound acid. We cause our patients to be metabolic acidosis. Notice I say, I cause it. Yeah. So in what moments should you fix SpO2? 3 to 5 minutes. We got 3 to 5 to fix this problem. How do you fix it on a vent?
Can you change your FiO2?
Turn the knob.
You can turn a bunch of different knobs.
We're getting to one now. The first way.
I'm not saying which ones. You just asked how. I said, well, there's a bunch of knobs you can turn.
The very first way to fix a low SpO2, number one, right? And we'll get into number 3 in a minute. But number 1 is increase your FiO2. And can your FiO2 be too high? Yeah, free radicals. Perfect. Why does a non-rebreather not work on CHF patients?
No pressure.
Right. I can actually get the heck out of their nose and their face and their ears, right? But I need pressure. Everybody on board with that? So what device do we use? EPAP. You've been using EPAP all your career, right? So why not EPAP with an SpO2 of 21%? Oh, no, an FiO2 of 21%.
Yeah.
Because they don't need oxygen. We're doing a guy that does a triple Lindy off the backboard into the swimming pool with no water and fractures C4, breathe no more, C5, stay alive. Not moving his diaphragm. What does he need? Yeah. What happens if I give him an oxygen? Not a rebreather.
Doesn't do much.
He needs the push. On board with that? So why not a BVM and not plug it in?
You don't have to plug it in.
Right? You with me? We just need to maintain the SpO2 above 94 and below 99. Turn the knob. Number 2 way to fix your SpO2. Number 1 way is what? Number 2 way? Correct. What happens when you lay a pregnant lady flat? Yeah. Pregnant, sterling, preload, all that stuff, right? What happens when you over EPAP a stomach? Decrease blood pressure. Can you have too much? Pee. Yeah. I'm going to tell you, I'm not allowed to say this, I'm allowed to say follow your local protocols. Did you hear me say that? Follow med control. I'm going to parrot that all day long. If you're at peeps around 14, 15, or 16 on a COVID transfer, you better have a presser with you. You with me? See how that math worked out? Even before you get going, hey, they've been riding this for long. Then we'll put them in the back of an ambulance. I'm going to stimulate the heck out of them. What's the demands of the sedation going to do? Go up. What's the demand of the hypoxia going to do? Go up. Right?
So we need to increase the sedation.
And you know blood pressure is going to shift when you do that. And it's a predictable outcome. I got to go look at my magic ball. You got to know before you go.
Any stimulation of a critical patient will dump their vitals as well. Not just, I mean, that's one of the things that I learned in that ICU rotation I did.
Yeah.
Was they go in to do their fluff and buff every 2 hours. Just to roll them, rub the lotion on their ass, and roll them back, they bump their pressures up.
Yeah. That's good nursing too. And with me, how we really do want to. We talk about fluffing asses on it, but that's good nursing. Yeah. Can I show you that? Can I need a volunteer?
Will you rub lotion on my ass? Dude, I'm here.
I need a volunteer, not him.
I said on.
I'll bring your back. I need somebody to stand up for me. Close your eyes.
Turn around, bend over. I'm a paratrooper, you can
I
take it.
am not going to touch you, okay? You're absolutely safe. In a non-safe zone, you're safe. Wake up. One of these days I'm going to be punched if I do that. How'd that be?
I heard you coming.
All right, but still, you heard me coming to you, knew I was there.
Yeah.
And you still, did you see his endogenous catecholamines? He got red in the face, his heart rate physically went up. And they even told him he wasn't going to get hurt. And I'm not going to touch him. he still had this triggered flight or fight response. Do it again, close your eyes. This time, I'm gonna tell you, I'm gonna walk into your space. All right, can you hear my feet? I'm gonna start. Just this feet. Sir. What's the difference?
Gotta go on my hands.
What did you feel that?
Yeah.
And did you hear him take his breath? Follow that? No chemical dump. Relax. Yeah, thank you. If you want your dental patients to be better, be a gentleman to them, or be a lady to them. Be kind. Whisper in their ears. When you sedate patients are paralyzed, and the last sense to go away is their hearing. They can still hear you. They can still feel you. Talk to them. Call them a man or sir. Right? Shake a man's hand. I know he's paralyzed. I don't care if you can feel that. You with me? And your vent transfers will be going if you do what your grandmother and your grandfather taught you. Okay. And if you don't want to fight with Narcan patients, and wake them up, they fight, stop that. Tell them you're right there. Introduce yourself as a gentleman. Your life, and forget just the politeness and kindness of it, right? The medicine is better.
I got terrified. Who the fuck are all these people?
Right?
They do.
Yeah, yeah. And legitimately so. Yeah, so tell them, hi, my name's Eric. The number one way to decrease SpO2. Thank you. What's the problem with too much FiO2? Yeah. The number two way to decrease SpO2.
Pressure.
Pressure. CPAP, EPAP, whatever we call it, right? What's the problem with too much of that? Barotrauma. Before barotrauma, you're going to see blood pressure tank. Way on work, you appropriately gave me a great answer of what is tidal volume. What was your answer? Absolutely, right? That's the textbook answer. Now, I'm going to redefine that textbook answer. If I turn my FiO2 to 100%, right? What is tidal volume? The number three way to increase your oxygenation, if you're using PaO2 or SpO2, is increase your tidal volume, which is what you said a minute long. But there's some steps in between, right? Now, what's the problem with what I just said? If you increase tidal volume, what do you increase?
Pressure.
And what's the problem with too much pressure?
You need more.
Blood pressure, barotrauma.
Yeah, that's the dance. You with me? That's the dance.
I'm gonna throw something else in there, but you can yell at me and say, whoa, 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 go slow. Let's not ignore when we're choosing FiO2, heat, rate, depth, all that shit, what our CO2 is.
Okay, so let's go there. Thank you. Nice lead in. What's the normal respiratory rate in the adult man?
It's funny.
And if you don't know that, please leave. What is normal breaths per minute in the adult male? Thank you for stopping me. By the way, I'm standing right here so the camera can get me. So if you can, I have been accused of being too loud. So as a personal growth thing, I'm trying to be more subtle when I teach. But if I'm not loud enough, then please tell me. What is the normal breaths per minute in the adult man? Same thing, right? What's the normal frequency of respirations? 12 to 20. Same thing. Different vents and different machines call it the same thing. So if you go to the emerge on the transport, and the respiratory therapist looks at you and says, hey, their frequency of respirations is 22. What does that tell you? Same thing. And you weren't wrong either. You're 3 steps ahead of me and you don't even know. Very nice.
We might want to know why is it that.
We got to ask the question, right? We're into the next question. There might be a good reason. Okay. Hyper or hypoventilated head injury patients?
Normal. I don't know.
Hyper or hypo?
Based on new readings, normal.
Hyper or hypo head injury patients? It's a crap question, by the way. I'm actually setting everybody up in the room for failure.
Full.
Hypo?
Both. Well, depends on what you mean by asking. Like,
If they have an active TBI, Cushing's triad, you want to squeeze the bag faster or slower?
No, you didn't say that.
yes. but
That's
no,
squeezing
like
it back
fast
how many
enough
times
to-
per minute, that's the difference.
Fast enough to target an end pedal like 30 to 35.
Yeah, they're smarter than they are there. Yeah, right. And I can hold myself there, but you also know that. Yeah, target and entitled CO2. It's a crap question. I don't care what the rate of the bag is. If your entitled CO2 is up, how do you get it down? If it's low, how do you get it up?
Okay, so
Well, you can change all that though, a number of ways other than just rate.
Hold on.
it could be,
But we do, I mean, we think rate first,
Think rate first, because rate's too easy to be.
but
This is dad versus son.
No, this is not it. This is people learning together, right? Yeah.
But we think rate, and that's all we can do with a goddamn bag valve mask. But you
Right.
can change tidal volume
Two,
and change CO2.
Right.
five,
If you have the right vent,
8,
you know.
9, 10. 10 breaths per 1 minute. Let's write this down. Normal respiratory rate, 10 breaths per 1 minute, 10 to 20. Everybody on board with that? Normal TI, time of inhalation, takes what, 1 second to inhale. Our factory preset is 1.3 seconds. Our factory preset for time of inhalation is 1.3 seconds.
So when you fire it up automatically, it just comes at 1.3. Okay.
And if our entitled CO2 is upper, by the way, what's PA, what's normal? What should our PaO2 be at? 80 to 100. What should our SpO2 be at? Same thing. What was that? What is a normal entitled CO2? 35 to 45. What's normal pH? What's normal entitled CO2? See what I just did there? Absolutely, as a paramedic, you should know what all gases you're doing. In a healthy patient, and entitled CO2 and pH are 1 to 1. If they're unhealthy, they separate in different ways depending on what the etiology is. The etiology, we're starting out in us in this room, it's a 1 to 1. Perfect. Correct your blood gas, please. Perfect. What gas do we inhale? The one we care about, the big one. Oxygen. And what device do we use to measure oxygenation? Fabulous. What gas do we exhale? Yeah, what device do we use? CO2. What gas do we use? What device do we use? Fabulous. Stop saying that entitled CO2 is more accurate than SpO2. Stop that. It's not. We're measuring 2 different things. If you change your FiO2, your entitled CO2 won't change. If you change your respiratory rate, your SpO2 won't change. 2 different things. All that. What's our factory preset for INE ratio?
1 to 2.5.
I said it right.
No.
No, you said,
Oh, 1 to 3.
Eye
Thank you for stopping me. 1 to 3. Our factory preset is 1 to 3. If I have 1 second eye time with a 1 to 3 ratio,
1 to 3 ratio for our time.
yeah. So what is our E time then?
1.3 times 3. Is that 3.9?
If I have we just do 1. 1 second eye time, 1 to 3 E time. What's our E time?
3 seconds.
3.
Three.
If I have a 2 second eye time and a 1 to 3 ratio, what's my E time? Excellent. Perfect. Everyone on board with that? It's a ratio. What patients? You guys tell me what patients need a longer E time. I love it. Blue bloaters, pig puffers, right? And they breathe up longer.
Mathematics.
Asthmatics. Yeah. What patients need a shorter eye time?
But we're gonna be able to do that in the field.
Yes.
You can do it now.
How are you gonna increase the exhalation time?
I'll answer that. Give me 2 seconds. Give me 2 seconds to make this example and I'll show you.
With the vent you can. Well, I mean, with the BBM you can too.
Yeah. Okay, so what patients use a shorter IE ratio? Diabetic
Yeah,
ketoacidosis?
anybody, yeah.
Traumatic brain injury. Yeah. What breaks my heart to we all take these to Maine Med or to Boston is that 13-year-old girl that takes a whole fistful of aspirin. This is not weed. Weed's illegal. The aspirin will be fine. And then she gets that big aspirin before. It's called acetylsalicylic acid. She gets a sit and very acidic. And, she goes to Boston for a transplant. Those are heart failures. But the acetylsalicylic acid, we need a short binding ratio. Everybody on board with that? Perfect. Conceptually, these concepts are in your brain already. I'm going to go on a bit of a rant, a tirade, a rant. Get up on my step stool and preach. I hate when people say, what are the appropriate bed settings? That's the stupidest question ever. The question should be, what is the appropriate treatment for this patient? And then I'm going to choose this tool. We don't treat machines. We don't put settings in machines. We treat patients. And if you know what a good exhalation phase is, COPD patients, we know we need to let them breathe out longer, then you make whatever tool you have do that. Does that make sense? Cool. Let me show you how to do that. If they have 10 breaths per 1 minute, yeah? And I count that 10 breaths per 1 minute in half. And I now have 5 breaths per 1 minute. 1, 2, 3, 4, 5. What did I do to my E time? Yeah.
That's 1 to 6.
And if I take my 5 breaths per 1 minute, and make it 20 breaths per 1 minute, what did I do to my E time? There you go. I just changed the IE ratio. Now you just said that's 1 to 6. That's math I can't do. That's first grade.
Dude, I'm in college math.
No.
Oh, yeah, he's taking a class. Yeah. This is right off his,
What I will tell you, what's an average? What's our factory preset for eye time?
1.3.
Yeah. If I make my eye time longer and keep my respiratory rate the same, what do I rob from? Yeah, your E time. If I make my E time longer, but don't change my rate, what do I rob from? The vet does the math.
It's a good thing.
Yeah, right? Physiologically, ladies and gentlemen, what I expect you to do is to know what patients need to breathe out shorter and longer, and then you just make the tool do it. Thank you. Perfect. Everybody on board with that?
So your factory settings, 1.3 with 1 to 3 comes out 11.5 breaths per minute.
No, we do it the other way. Our factory preset are 12 breaths per 1 minute with an IE ratio. So our eye time comes out to what?
You have a 1 to 3 factory ratio.
1 to 3 is your eye time.
Right. So if you have 1.3 to 3.
Yeah.
So
See, I can't do this math. I cannot do this math.
So if you have a 1 to 3 ratio, it's 1.3 to 3.9.
11 or 11.5.
All right. Which is 1.3 plus 3.9. That's 5.2 seconds per breath total, in and out.
I can't do that math.
60. I got
You got to calculate in front of me.
60
Don't have to,
divided
that
by
will do it for you.
5 point. I know, but 5.2 is 11.5 breaths per minute. 11.5 cycles.
Cycles. Oh, there you go. Cycles.
So
Cycles.
that's
Yes.
per minute.
So is the exhalation time ratio the inhalation time is 1 and the exhalation is 3, or is it a range?
It's a ratio.
Okay.
It's a ratio. So let me start with our I to E ratio is that. So it makes sense as opposed to putting a colon in the middle. Put an X. Multiplication. Yeah?
Yeah, I just thought it was a 1 between 1 and 3, not the ratio is 1, 2, 3. I get it now.
Thank you for stopping me. Oh, like an arrow, 1. Yeah. Thank you for stopping
I
me.
thought
Well,
it
it
was
is
the range,
1.
not the ratio. I misunderstood.
That ratio is 1 inhalation to 3 exhalations. So it's a time ratio, so whatever your inspiration is, if you're at 1 to 3, that 3 has to be 3 times longer than your I.
Yeah, I really know how I'm being a good instructor today, and we're learning a lot. There's a couple ways, because people are leaning forward, because we're really going on some tangents, even though those tangents are relevant, right, and important in learning. People are stopping me and asking questions. So I think we're having a great program. I like this a lot. I am doing such a great job that nobody knows the Dunkin' Donuts in the back. Oh, let's take some dollars.
That's bullshit.
Oh, I need a refill of my coffee. I mean, 1 to 3 is easy when you think 1 second.
Right.
But when you start to add
The
the decimal
unit,
point,
instead of going seconds per unit, it's 1 unit to 3 units.
Great.
That's what I wrote down.
All right, how are you?
Well, Matt,
nice. Yeah, I got back yesterday at lunchtime. This weather's bullshit.
You got it.
I was reading online.
I thought Massachusetts is online, New Hampshire's in person. Kevin, is it Massachusetts doing online and New Hampshire doing in person?
Or we have to do both.
Okay, where did when that guy?
Ah.
I'm gonna mute for the moment until we start back up again.
All right,
All right, we're gonna get started again.
I'll do that online.
Okay.
So if
I'll
we
discuss that
rewind,
with you next week.
Just to clarify.
what is FiO2?
Fraction of inspired oxygen,
Fabulous. What is it?
the amount of oxygen that comes in. from the breath.
Perfect.
It's gotta be math, and it's got the word fraction.
What is PEEP?
Positive and expiratory pressure.
What is EPAP?
Oh, fuck, I don't know.
See above.
The same.
The same. Thank you.
Yes.
What is CPAP?
Same thing as
Same.
Thank you. What is tidal volume?
The amount of air that goes into the lungs.
Nice. And if the FiO2 is 100%, what is tidal volume?
They're at by
The amount of oxygen that goes in your lungs. What is respiratory rate?
No.
Fabulous. And what's I/N/E ratio?
What's that?
What is I/N/E ratio?
the ratio between the inhalation time and exhalation time.
Excellent. And what's TI?
Story time.
Yeah, if you understand all of those things, we're done teaching mechanical ventilation.
Yeah, I don't understand all.
So TI, so here's a question, maybe you know. Tidal volume is VT. Inspiratory time, TI. What kind of Greek bullshit is this? Who came up with this?
People that make more money than you and I, right? Right? People that
Shouldn't it be TB for tidal volume?
Kevin, you need a hug, buddy?
It's because there's a different ton of different volumes measured, so if you're doing volume of tidal, volume of this, volume.
I get
of
it,
that,
but it's like Greek.
Time of inspiration.
It should be
time of
tidal volume.
Don't worry about it. They didn't have this when I took my paramedic class.
Think about this. 12 leads, right? All we had were like back fives and, ooh, lead two. Don't even get me on that.
need to, you have no clue. Yeah, yeah.
Bingo, baby.
All of that to say, take it the next step. We're in a car and we got a wreck. And I'm in the car and I'm in the front seat and I'm doing type medicine. I'm doing my medicine. And we're cutting, no, in that car, not this car.
Outside of the backs.
Yes, right, that one. And somebody is on the outside cutting the beam post.
Yeah.
What happens when I take my hand and put it in the way of the cutters?
It's a bad day.
Now there's another patient.
Yeah, you have less hands.
Right, short conversation. Hopefully, that Jake running the jaws is paying attention and sees that it stops. Nope, sorry, right, I apologize. Not happening. Do the jaws change the rate? Do they change their pressure? Do they change their volume? AC mode, assist control. Some machines call it ACMV, assist control, mandatory ventilation. The key word being control. Some people call it a vent send mode. What the vent is sending, which is often different to your point, Mr. Jennings. What the vent sends is not often what the patient gets, right? Two different things. A vent send mode, AC, assist control. Let's talk about this. Let's say we use that generic number of 500 tidal volume by a respiratory rate of 10 per minute volume of 5 liters, right? What's the half-life of Recuronium?
Half of the transport.
Thank you. Right, everyone board with that? Whatever rock you want, right? Halfway there. And we get to halfway there, and the patient starts to wake up and breathes in 2 breaths. Because they're slowly waking up, right? They're getting soft. And the patient breathes at 2, and the vent sends 10. What's the patient going to get in their lungs?
12 times 500.
Right?
So they're gonna pop their lungs.
What is volume married to?
No, the assist control though, once they take a breath, when they trigger that,
It is a vent send mode. Vent does not recognize that breath.
Sounds like they need to fix that.
No, I like that me a lot. I love something. So if the patient breathes, the vent sends 10 and the patient breathes at 5. What does the patient get in the lungs?
15
Everybody on board with that?
breaths.
And I'm a big fan of some AC mode. I love me some AC mode. If what? You got it, right? You have to own that responsibility, right? I own that. And if I increase sedation, if I increase stimulation, I have to increase sedation. And I love me some -6 trigger. But if I just accepted the responsibility of -6 trigger, what else in AC mode? It's more critical to think about -3. You with me? And if you can manage that, you have enough meds on board, it is a wonderful place to be. I love it a lot. But you better be on your game with meds. Fair? Oh, by the way, paralytics are longer half-lives than sedatives. Everybody on board with that?
Yeah.
So you have to be more concerned about your sedatives. They might be paralyzed fine, but fully awake in the brain.
That's Dr. Mengele.
You follow that? So I love some AC mode a lot. Good?
So I got just a quick question.
I got a
So
long answer.
If this is a basic level skill, is that only for like a cardiac arrest kind of event? Because when you start talking about meds and shit like that, I can't do that.
Correct. So when I use the word meds, I'm outside of that scope.
Okay, I just.
But for
wanna make
cardiac
sure we're on the
arrest,
same page.
in the state of New Hampshire, in a cardiac arrest, this vent we're going to play with is EFT based. For CPAP, it is.
Okay.
For paralyzed and intubated patients, it's not anymore.
Okay.
So there's definitely a slippery slope.
I just want to make sure that I'm with the same scope.
Perfect. I appreciate it. It's a good question.
I mean, but knowing the men up here in the back.
No,
Or
that's
not
it.
a lot.
Yeah, that's good.
I did that too. You know, assisting is a lot different than actually.
Yeah. If it goes on the bus, never mind, I can't say that.
Exactly, but
So, SIMV mode. Synchronized intermittent mandatory ventilation. The key word being synchronized. And some people in the field call it a vent or a patient pull mode. AC mode, people consider a vent send. SIMV, people consider a patient pull. Are you on board with that? What's the half-life of rocuronium? Half the trip, right. And we're driving down and the patient starts to get soft and the patient breathes at 2 breaths per 1 minute. What's the vent gonna send? 8.
In the city mode.
In the sim.
Yeah.
If they're pulling enough tidal volume.
Hold on, I'm playing checkers, you're playing chess. No, even if they're not, it will still recognize the count. So to answer your question directly, no, they can still pull their breath even if it's not enough.
So it's up to pressure support and then up to.
Yeah, wait till we get to the 3rd floor. But yes, pressure support is next. So if they breathe at 5 breaths per 1 minute, what is the vent gonna send? Yeah. If they breathe at 50 for a tidal volume, what's the vent gonna send?
Not
450.
for the volume.
Yeah.
Oh, it finishes out the breath. Isn't that AC though?
Yeah, I thought SimV just gave them what they pulled for volume. Right, so, because this is what we did at Exeter, based on what, I can't remember his name, the head of respiratory was set up with us, was if we had it set at 12 on SimV, they would get their 12.
No matter what.
Right, and if they pulled 5 more at 20, they'd only get 5 at 20,
Correct.
so they weren't breath static,
Yeah.
which is why he recommended we use that.
And, on that tangent, that's the wisdom, right?
Yeah.
Some people consider SIMV an outdated mode and will lose their mind when you say, hey, let's set up an SIMV. Now, I disagree with the statement I just made. Other people consider SIMV a vent weaning mode. So when you say, hey, I'd like to go into SIMV, they're like, why? We're not going to ruin the patient. But they don't understand how much we stimulate in the back of the neck. So I disagree with both of those things I just said. However, it's worth mentioning it so when you hear these other contradictory statements. So SIMV is a set rate. Right? If you want to rate a 10, if the patient breathes in and out of that might send the difference, right? But not a set pressure. It will lift the pressure. In AC mode, they won't meet the pressure. They can exceed the pressure requested. Does that help? Cool. Yes? SIMV with pressure support. Let's not go there yet. I'm going to get there. Well, let's start at SIMV at rate of 5 is what, as from a correct end-tidal CO2, I'm going to pressure of 5. Or end-tidal CO2, my rate is 10. Everybody aware with that? For my end-tidal which I made the decision at 30, and the patient breathes at 5, what is the vent going to send? Excellent. If the patient breathes at 8, what's the vent going to send? If the patient breathes at 10, what's the vent going to send?
No.
CPAP. You get that? That is straight CPAP,
Or BiPAP, depending on what you have for settings, right?
which is why we're going to get into pressure support in a minute. Yes, correct. You follow that? Excellent. Same thing. SIMV at a rate of 0 is EPAP. You've been using EPAP all your career. You've been using SIMV at a rate of 0 all of your career. No, because you asked me 3 times specifically about breath stacking. Let's talk about our flow waveform or our pressure waveform. Oh, it does it in pressure also, by the way, BT does. If I'm in targeted pressure mode, then SIMV will add the pressure to it. So if I want a pressure of 25, they only breathe at a pressure of 20, it'll add the extra 5. So it can be not in targeted volume mode, but in targeted pressure. Now, we know that pressure, before I get to the graph, we know that pressure and volume are married. Everybody on board with that? So if my volume goes up, what goes up?
Pressure.
Excellent. My volume goes down?
Pressure goes down.
Excellent. Good, good. When I'm fighting fire, I can put more wet on the red using 2 things. Pressure or volume, right? Smaller hose, more RPMs. I need more pressure when I need to push it. That dining room table does not stand a chance. Right? I need more volume when I need to decrease BTUs and drop heat in the room. I might drop a big old volume fog shield. There? Excellent. It is the same thing, and I'm going to start into a conversation that will last 4 days. I'm going to give you my opinion. I'm going to give you some dissenting opinions and tell you why they're wrong. I cannot wait till my opinion is medical fact. It'll be a great day because I said it. I also want something named after me. You know, there's the Achilles heel, there's the circle of the list. I want the sphincter of Kessler. Can we I'm happy with that. If the patient,
Good thing that was far enough away from the speaker.
He was talking about an endotracheal tube,
thank
obviously.
you.
Of course he was.
That's how you illuminate the way.
Yeah,
I was gonna say, I thought that was an MBA.
It's safe, it's effective.
What patients need pressure lift in their chest?
The big wiki in this?
Yeah. A flail chest needs pressure lift, right? A neonate, they need pressure lift. Just a little bit of pressure, but we're still going to look at pressure to make that happen, right? Perfect. But patients need oxygen. That's our primary concern.
All.
They do 21% just fine sometimes.
Going under 94% shot.
Yeah, polycystic drug overdoses. They took a whole fistful of grandma's, I don't know what pills, right? What was the cold medicine that they used to take?
Yeah.
Robitussin. Yeah, Robotrippin.
Yeah. DMX in it?
Yeah. Remember all those patients? Do they have a chest problem? No, they have an oxygenation problem, right? So my opinion is, and I cannot wait till my opinion is medical fact. It's just one guy's opinion, and there's a whole bunch of other opinions out there that make sense. If they need lift, it should be targeted pressure ventilation. If they need oxygenation or chemistry, it should be targeted volume ventilation. Does that make sense? I have heard if you're not in pressure with peds, you will kill them. Did I disagree with that? I have heard with ARDS patients, you have to be in pressure ventilation or you will kill them. And I think it's all crap. About 5 years ago, the state of New Hampshire is part of the IFT program, and it's changed. The terminology has changed. But as part of the FTI program, they said that paramedics could take patients in pressure mode, or in volume mode, but not in pressure mode. If that was in pressure mode, they needed an RT, which was unique because the RT would say, okay, pay attention to what volume they're blowing and change the pressure to volume. And okay, they're not in pressure mode, they're in volume mode. Have the trip. Good day. What we know is the flip side of the same coin. If you understand the volume and pressure are married, it doesn't matter what you're targeting. You just have to make sure you have enough of the other. And how do you get more or less of the other?
Lower.
That's it. Yeah, very nice. Very nice. So if they're in SIMD mode at a rate of 0, what are they getting? Yeah, like this. And if we call it, by the way, if I take an ET tube and pass some plastic and put no PEEP, their PEEP goes to
0.
right. Their lungs collapse, we have no reserve tidal volume. Right, it's gone. And we have to lung recruitment maneuver. If I can keep that continuous positive airway pressure in the lungs, the BPM is intermittent positive pressure ventilation. Squeeze, it goes up, relax, it goes down. Squeeze, it goes up, relax, it goes down. Yeah? If I have continuous positive airway pressure and positive airway pressure, then I can have a PEEP of 5. Some years more.
Would that be one of the reasons why state of New Hampshire went to cuff endotracheal tubes for pediatric patients?
AHA guidelines changed because they move them so much. The theory for a cuffed patient, uncuffed, not a cuff, is in this conical system, right? That you can sit in there and get a bit of good seal and have no peak leak. But the reality is we move patients and it goes on.
Yeah, right.
Yeah. Those secret, can I tell you a secret? We move patients, right?
Yeah, it wasn't just New Hampshire, it was PAL.
Yeah,
Yeah.
I'm gonna say, yeah,
Yeah.
everything that.
Yeah.
But
The original concern back when we were pups was that the cuff was gonna cause damage, necrosis to the trachea. But then, if we don't blow that cuff completely full, if we let it equalize out,
Right.
we don't cause that necrosis.
Yeah, the same problem with combi tubes, strangulation from the inside out. Right? Just so you know, my friend, paramedic stuff.
Yeah, I think it's
Yeah. All right, what is a normal peak inspiratory pressure? 20 to 30, fabulous. So let's call this 25. On the graph, this is what you're going to see. And you can watch breath by breath. Right? What's a good peak inspiratory pressure for a flail chest?
30.
30, 20 to 30. Above it, we're crushing bones, and below it, we're not oxygenating anymore. So on each breath, we want the pressure waveform to come up to that, and down to that, up to that, down to that. Right? And I drew 2 quick ones real sharp, which aren't real kind, but they wouldn't be like that to be more flowing. How is it bad? But to answer your question, Mr. Jenks, I want my PEEP at 5, and then the PEEP's at 6, and the PEEP's at 7, and the PEEP's at 8. Rest stacking. That's the first thing. Actually, a whole bunch of parameters. So as this graphs up, rest stacking. Perfect. 2 more concepts that I want to talk about at the paramedic level, and I've been doing this for a while, and I've been a paramedic for a couple of days, like everybody in the room. I'm going to describe these 2 things for you and tell you I've never used them. If I have 1 breath, and the top of that breath is at 5 of PEEP, and the top of it is at 25 of PIP. The rise of that breath, and if we want to take a volume of 500 and at 25, or a pressure of 5, how quickly you get there. You can have a time stamp of 1 second for an I time. You can also have a rate of rise. So in 1 second, I can go slow and comfortable, more comfortable, or I can have a slower rise time and get it in quickly. Patients that are sick and dying, I need to shove that air in now. So I don't mind a faster rise time. Patients that are uncomfortable on a mask, I can do a slower rise time. And the rise time scale goes from 1 to 10. It's a subjective scale. Our factory preset is 2. I think 2, might be 3. 2. Let's go 2.
So it's more work on like bypass patients where you're trying to make them feel more comfortable with how fast they're breathing.
Yeah.
And they're breathing.
Yeah, and let's talk about cycle off time, and then I'll answer that more. Cycle off time is how quickly or aggressively we get off of that, if they're at 500 or 50. And this is at a percentage. And our factory preset is 40%. let's say we have a tidal volume of 500. If it's 100%, if the cycle off time's at 100%, as soon as they get here, they immediately go down to get it all out. If they have a 10% rise time, then they go this way. Much more comfortable, but it also takes longer, and they don't oxygenate as well quickly. You get more so, that's a problem.
So the shorter rise times, shorter cycle off times for better oxygenation equals more sedation paralyzation.
Yeah, but this is with a breathing patient.
Right,
So,
yeah,
yeah, when it comes to slippery slope.
Well, or sedated patient, not paralyzed patient.
Correct.
Yeah.
Well, but couldn't you oxygenate better with a longer exhalation time because your mean airway pressure is staying elevated longer?
It's all auto flowed. That's not a thing anymore. Did you follow that?
No.
I'm sorry, say again?
Hey, sorry. You want feedback?
No, thank you. Somebody went to CCT school. Where'd you go to CCT school?
I did
Where'd you study vents?
everywhere. And
Cool. This vent works differently than that. If you set your settings, it will meet the demand. It changes the flow of this. So you don't hold your flow doesn't flux at all. It always stays where it is. What flows is the tire of flares. Does that make sense?
kind of
Okay. Some vents, tangent, they are flow triggered vents. So if I have my patient over here, and he's sad, and I got a tooth going in his mouth, right? And I have a vent over here. This is continually filled with air. And we know that if I'm fighting a fire hose, my fire hose is loaded with water all the time. I have a dynamic pressure. On some flow cycle vents, you can increase the water pressure in here, and when you increase the water pressure here, it changes rates over here. If you increase flow here, it changes continuous positive pressure over here. It changes many things. If you increase or decrease the flow or the pressure in here. Some vents are flow cycles.
So by flow cycle, you're talking like the leak blowers, right?
No, I'm talking about the Hamilton T1.
Okay.
Yeah. The Hamilton T1 always has air in the circuit, and it's always pushing the pressure.
But isn't also like constantly cycling through the vent, and like when you take a breath, it senses a change in the flow and it.
Yeah, and correct. That's how this vent works. The flow changes from the patient breathing or from the vent sending, not by changing the flow, not adjustable flow. As a provider, you don't adjust the flow. You tell what, you set up your numbers here, and the vent automatically changes the flow rate. Old school, it would change the flow rate and it would adjust the numbers. Does that make sense? The leak blowers held it there and then just shut. Every time you want. So, let's take this to the next step. Now that we talked about pressures a little bit, and then we know that SIMV at a rate of 0 is,
See that?
forward with that. Let's go down to non-vented or paralyzed world. No tube in the hole. We have a mask. And let's do mask ventilation now. EMT basic level question. In order for me to use mask ventilation, what does the patient have to be doing?
Breathing on their own.
Everybody on board with that? They have to be maintaining well. They have to breathe in on their own. Maintaining well and breathing on their own. Are they going to be breathing well?
Probably not.
That's why we're here, right? Yeah, right? Random tangent. I've never changed cycle off of flow time. I say, well, when I cycle off a rice time, I've never done those two settings. I had much more success doing things like coaching a patient, talking to them, hey, Kevin, will you take a big fast breath for me? Will you take a slow breath? I don't have to mess with the vent. I simply ask my patient very kindly. The advantage of it is if the patient is breathing faster than the vent and the vent is banging at the same time, then we have synchrony problems. So I can pull in and drop those to make sure the vent and the patient are syncing at the same time. I've always accomplished that goal simply with courtesy and kindness, or morphine. You got to pick that dreams Morpheus. Helps that as well, right? And I had worked in a system that we moved to our side quicker than sit and mess with the vent.
One patient, someone, Brandy was telling me that you're using Versed for the program CPAP. It's been helping them a lot.
Yeah, and it's bold, right? Why is it bold?
Because the thing just dropped around
Yeah, it takes their catecholamine response away and their drive. You don't
Not using 2.5.
Yeah, and I think it's good, but you have to know the wisdom and the responsibility to just
It's
accept.
just 0.5 as an anxiolytic, so that they don't freak out the mask.
Yeah.
But being polite, I hold the mask for them. I'm gonna talk.
Yeah.
Yeah, let me know.
Yeah.
Yeah,
I don't just,
and wisdom and we grew up in St. Louis.
Or even let them hold it for us.
yeah.
That's not a question, as far as for their, like, we had a journal, in reference to, like, high flow.
Yeah.
Is that something that advisable as well? So,
And I'll go there because you asked. High flow nasal cannula, if you take, here's the short story, it's much more complicated than this, but I'm a redneck. So you know the Narcan nasal things? Yeah, if you take those little cones and put it on nasal cannulas and shove it in the nose, you get a nice seal. They can turn up to 15 or 16 or 55. So you get pressure off of that. And that pressure from that is pressure. High flow nasal cannula pushes fluid out of the way. From the patient's point of view, they can still eat. If they're having trouble breathing in a long-term service center, they can still eat, they can still drink, they can still talk to their family and all that stuff. In a emergent world, CPAP, we're done. Fair? But a lot of people are dealing with it, and there's a lot of demand for transport, high flow nasal cannula. This vent does not.
What's the setting on the high flow nasal cannula regular? I'm just thinking about regular on the oxygen tank.
Right, and it's a whole new system. You'd bring it here.
So our units right now could not accommodate that.
There's if I remember correctly, it's kind of like a little leaf blower that you plug in and your oxygen goes into that and it cranks up that flow from your 15 to 55.
Yeah, but hold on.
Would that still run off? We'd have to run that off the 50 PSI outlet?
I don't.
While we're right here, good point, sir. These vents do not run off of the Christmas tree. So coming out of the wall, you have the regulator with ball that goes up and down, and somebody can take off the Christmas tree and split it. Yeah, no, please don't do that. Take the regular vent. Perfect.
Have we checked to make sure that this vent has or that we have the right adapters for our trucks?
Just came in last night, so.
Because like the LTV at Huggins, for example, because Huggins wall has different outlets, does not plug into Stewart's, right? They had to buy an adapter.
So we have an adapter for the memorial walls for the HD70. Then we have the ones that go to the bottles that connect to our trucks. I just want to make sure all that's there.
Yeah, I just want to make sure.
The one for Huggins is different, I think.
The
So,
hospital ones are all the same. Connectors.
Sorry to interrupt.
hey, Jason, go ahead.
Hi. So get me this type of connector and I'll make sure that you have it.
All right, we'll do some research after class and we'll move right into that.
Because as far as I know, the hospital wall is all standardized. Unless they're doing something different.
I know it's not.
Each hospital's got different adapters, different plugs, unfortunately, depending on who their engineer was that designed it.
Yeah, we have the adapter for the memorial hospital wall where our contract is.
I don't know what
That would do that.
But I can do some research quickly with the gentleman here and the ladies here, and we'll figure that out for you.
Okay,
If on the vent, on the Z vent specifically, so far I've been talking about general mechanical ventilation. Let's talk about the Z vent specifically. If the number is hollow or outlined, it is what the patient is actually doing. Not what we want them to do, not what med control said they should do. If it's hollow, it's what they're doing.
If what's hollow?
The number is.
The number.
If it's outlined.
The number on the vent.
You can't adjust that. If it's a solid number, you can adjust it.
Let's talk about the number 1.
Not, oops, adjustable.
If it's hollow like this, it's what the patient is actually doing. If it is solid,
Well, that's what then.
it is what the vent is sending.
And is adjustable.
Correct. Okay. Correct. And I would suggest that the hollow number is adjustable also.
Wow.
Drugs and-
Yeah.
Right, right. So, and my point is, let's just treat the patient, right? Fabulous. And we'll play a lot with this. But if it's solid, what does that mean?
So it's adjustable by the vent.
Correct. If it's hollow, what does that mean?
So the patient's doing.
Adjustable with rock.
Okay.
You make 50 into a 0 easy.
Thank you for the coffee.
Yeah, thank you everyone for the coffee.
Let's talk about this patient that's in full failure, and I'm going to consider mask ventilation. We want a couple tangents and answer some questions. But what does the patient have to be doing? You answered that correctly a moment ago.
Breathing on their own.
Under the word breathing, what other components am I going to evaluate as an EMT or paramedic?
Oxidation versus and ventilation.
Yeah, is it failure or distress?
Yeah. Right. Everybody on board with that?
Type of
Yeah.
failure. Oxidation or like.
Nice. Well, by the way, those words you just did, oxidation versus ventilation, you just triggered a thought. If it's a ventilation problem on my patient, I look pressure support.
Oh,
If it's
DQ.
if it's a oxidation problem, I like targeted volumes. That word. Yes, and I've heard, what's that?
Or CPAP or oxidation.
Stand by. Because I'm,
Or just bypass.
If you've got the ability to BiPAP, you shouldn't CPAP. They're more comfortable.
let's talk about this.
They work that.
What we're going to do now is go both steps. You just said BiPAP. If you have, you should always go with that. Let's talk about a slippery slope. Let's first talk about CPAP and then look at classically why the two things go together. Nice CPAP. That's good CPAP. Increase your feet on left. Fabulous. Let's say if it's hollow, what does that mean?
So the patient's doing.
Patient draw.
Thank you. Thank you. Now let's rewind and do what we do well. The rest of the world has no idea how good pre-hospital medicine is at seeing patients. We walk into the room, into the doorway, we look at the patient. We can subjectively assess their cytoplasmic, their next one. We can subjectively see their work of breathing. We look at their shoulders, we look at their eyes. And we can know how the next 20-minute call is going to go, right? We're good at that. And then when we get to the emergency room, the staff looks at us, and how are they? And we say things like, oh, they're FTD, or they're going to die. We're not going to explain what we see. Everybody on board with that? Yeah, but we're really good at, do not, please, ladies and gentlemen, please do not forget what you know at the door and you've been on your career. Do not lose that assessment, please. Everybody on board with that? Keep that tight to your medicine. We're better at it than anybody. If you walk in, and let's say their tidal volumes are 200 in an adult. Is that good or bad? The respiratory rate is 40 as an adult. Is that good or bad?
It's bad, but it might be good for them.
Because they're working to get there.
For the 200.
Right, but if they're in
So there's your own-
DKA,
But we're not, we're in full failure.
right, but I'm just, you know.
You're right, correct. We need to take that not to just an objective thought, but we need to clinically figure out why the underlying etiology is. We don't have the symptoms, we treat patients with the tools. The tool we're talking about is the vent, I don't care what tool you use, right? So 200 by 40, barely cover the dead space. And we give them a mask, right? We give them a PEEP 5 or a PEEP 10, because we're allowed to start with 10. Other systems have to start at 5, and then if it doesn't work, they go to 10. If it doesn't work, they go to 15, they have to do step. We can like 10, make it go home, right? And what is the very first treatment these guys get? Full CHF. Before then. Thank you. Right? Now, if you don't do that, none of that matters, right? Look, I got a cool vent. So? And then I put them on the mask and I'm coaching them and I'm holding them and we're talking through this. And their tidal volumes that were at 200 are now at 220, 230, 250, 300. The rate that was at 40 is now at 38, 35, 28. What does that tell you?
Better.
Yeah, it's working. Yeah, we're gonna go to med, right? We're happy with this. Let's do the same picture. They're at 200 by 40. And you give the mask and I coach him and I hold it and I do all those things. And then they're at 199, 42, 50, 150. Yeah, it's hollow. So you're going to be able to objectively see respiratory distress before it becomes respiratory arrest. Do you follow that? So when you get to the hospital, and the hospital says they're in CHF, why did you not use CPAP? Why did you lay them flat and easily intubate them? Your answer can be subjectively, their static lab assays were pulling, their intercostals were tired, the basement volume rate was bumping, and their tire volumes were 150 and the rate was 55. Okay? Right? Do you see that?
It's a good skill that hasn't been used for a while.
There's a great article out there called The Top 10 Things Every Paramedic Needs to Know About Waveform Capnography. And what do you Google on your phone? The top 10 things every paramedic needs to know about waveform. And it pops up and it's just good street things. 10 just really cool tricks. We are going to, because if you want to learn, you have to do. Everybody on board with that? So we're all going to stand up. What is your name again, sir?
What?
Yeah.
Chris.
Chris. I'm going to stand right here, Chris, and we're going to all circle around this table. That was. Good.
Good.
Somebody's gonna die today.
Now, I don't mind sharing my personal opinion if you recognize this is one guy's opinion. There. A lot of people love the backpack. I don't like it. Some people love it. Whatever, do what you like, The back goes on the outside, the other stuff, the accoutrements on the inside. I like to teach. Push down, turn it. If you
bring you
don't push
guys
down,
over.
You can't push it once, and it will break. Please remember to push it down. Fair?
Is it warranted?
I don't know the answer to that. Ask me about purpose. I'm good as a teacher, not as a technician. For the purposes of this course, I'm going to take it out of the cage, so you can put hands on it. See, it's pretty jammed up in that cage nicely. Specifically what happens is. All right.
That's yours, not warranty.
That's yours.
I can take you to the ER. You should be evaluated.
Andy, inhalation port. Here comes in here. Specifically, this is looking at two platforms, durability and oxygen use and battery use. So we got rid of the flow. And this sucks in everything. Please don't put your fingers in there.
Yes.
Yes, you
For
do.
some people.
Yeah.
Don't put anything in there.
Yeah.
Don't
It'll
just
get laid
say
like this
fingers.
on a blanket.
Right, and we'll talk more about it.
Prologue.
That's why the holds me. So if you lay it, it's still, yeah, because people do it.
Yeah.
Even we're talking about hazardous environments, you have the class A, full body white suit.
Mhm.
Then you have the class B with the purple 3M filters.
Mhm.
That will go here. So it's 100% hazardous environment approved. Yeah, not me, but Baxter gas, take this in. I don't care. Neither does the federal government, works well. SpO2 probe on the top. You'll never use that, well, because you have a cardiac monitor. But the US military and the Israel military buy a whole bunch of these, and they said, put a pulse ox probe on, we'll look at it. In the back is where the power goes. Before I talk about the power cord, I'm going to tell you that it is a 10-hour battery. Lithium ion. Power cord.
Which means we're really only getting 10 minutes.
No, these will actually run that long.
I mean, until we kill the batteries.
How frequently does that battery need to be replaced?
Every 2 years, 3 years? Yeah. And because it's lithium ion, thank you. We do have both the car power charger and the AC cord. It doesn't matter from my point of view. Because it's lithium ion, I'm not going to talk about nickel metal hydride or lead acid. No, let's talk about lithium ion batteries. The concept of a memory is antiquated and outdated. It doesn't exist. It's not a thing anymore. So don't ask. What do you mean?
No, the wall plug that goes into that end form.
You gotta buy that separate.
Oh, we don't.
It's a DLC.
Oh,
There it is.
yeah, here it is.
And yes, the oxygen power cord goes here, right? Or the power cord, I said power, so that 2B. You don't need to hook it to oxygen. It'll blow on FiO2 21% all day long without supplemental oxygen. And the advantage of that is a portable tank will last you for hours. My guess is you go from here to main med on a portable tank. Don't
Dependent upon the FIO.
No, at 100%.
Yeah, but it's only giving you 12 a minute, not.
Which is why we got rid of it. So that-
Yeah. CPAP or bypass kind of fleet.
I'll talk about that. Fair.
That's your
The man's
fault.
not wrong. The man's not wrong. We'll talk about that.
Or
Perfect.
my fault.
Perfect.
Take the hospital's venting.
Yeah, I'll go all that. Let's talk about all of that as we go.
Vented versus non-vented.
Yeah, you're right. But that was why we got rid of it. The number one way I have seen the Z vent break, ladies and gentlemen, is this right here. Works like an old school cigarette lighter. Remember the cars we were pushing and popped out? If you twist it, it will break. Please don't twist it. Please don't twist it. It is knurled like you want to twist it. Please don't twist it. Fabulous. And there's an arrow there, and you should take supervisor. Like that. You should take some yellow paint marker, white highlighter, something to make that arrow easier for the crews to see.
Oh, kind of like on the three-way vents. I mean, IV pumps that everybody goes in and twists and breaks off.
Right.
Yeah.
Don't
It doesn't
twist.
have a red dot on the top.
Right. Did I say it again? Don't twist. There. And if you don't know what a cigarette lighter is, then watch the movie Deadpool, where the cigarette lighter goes in the guy's mouth in the very beginning. Great movie.
You're gonna reference 8-track tapes now.
Man, I don't know, we're that old. So did a good thing. Traditionally, we think about
He said, "What's an 8-track?" I'm like, "Oh, that's."
Are you being serious?
I didn't say
That-
that.
Dude, my first car didn't even have an 8-track for technology yet.
2 vent circuits.
I got a record.
Zoll did a good thing. So this is a neonatal peds circuit.
300 to
Pediatric and adult thing,
200.
right? And so my answer in my mind, because I'm a sport, correct. What you said is absolutely correct. Say that for everybody.
The pediatric is for 300 and under, and the adult is from 200 to greater.
So in
300
my
and
mind,
under what?
ML.
Oh, thank you.
required tidal volume. In my mind, the number is 200. Less than 200 tidal volume, small. More than 200 tidal volume, big one. Which covers the little lady with the pneumonia in the nursing home. It covers midgets. All of those things covered. 5 keys and above.
I bet you the midget would be under. Might be under. Yeah, that'd be a midget. Yeah, that'd be a midget one. Yeah.
You're not wrong.
Very politically correct.
5 keys and above, not FDA approved for less than 3 keys.
Is that the case? Because I thought one was on the back of the torso. I thought that one should be the size of the collar.
Oh my
Every
goodness.
test is a-
I'm just asking.
Yeah, you're right. And so then we would go for ideal body weight over.
But if their ideal body weight's based on height of 3 foot 8 inches and their torso is my size,
Exactly, that's what I'm trying to say, yeah.
I don't know, use this
Just
to make choices.
Right?
That makes sense, yeah. Oh, unless it's the other kind of torso where it doesn't like.
Right. So they've got a normal sized torso.
That
No.
I will go here to the point. This is the exhaust valve on the vent. The same as the Newport ET70s. They have a half limb or a J circuit. Why that matters is all airway devices have exhaust ports. Bag, valve, mask, exhaust port. Non-rebreather has the orange flappy valve. This is the exhaust port. One exhaust port to roll them all. Some systems out there, specifically called Respironics, puts the exhaust port in the masks or in the elbow. They're called vented masks. And they will fail with this machine. A vented mask will not work. Is that direct enough? Yeah. And please, 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 don't put Tegaderm over it. One is better, it doesn't work. Don't ask how I know it doesn't work, just accept the fact. I know it doesn't
Duct
work.
tape instead.
I need somebody to either start counting or give me a timer, please.
1, 2, 3, 4, 5.
Admittedly, I work for Zoll, so I do this a lot. I've done this many times this week alone. Green one on the green one, clear on the clear one, big one on the big one. Yes, you can get them backwards, and the machine will fail if you get them backwards.
17,
How long?
18 seconds.
Yeah, 18 seconds. Put somebody on vent. That's why it's really stuck on the east side. Now, admittedly, I work for Zoll, right? But that's my goal. When you leave and walk out the door, you should be able to put somebody on the vent in 18 seconds. Not me, you.
So does this fire up automatically on that adult setting and that?
Which is why I've been.
It would be our preset settings,
Right.
what we set as a preset,
So let's play with that.
or default.
Everybody jump
Default
right in here. At the very top, it says SpO2. Listen, do you see SpO2?
Yeah, it says standby,
You're never going to use that. Why?
because we got a monitor.
Right. Next one says.
Well, wait a minute. The top one actually says heart rate
Heart rate.
standby,
Oh, I'm
then
getting back.
Heart rate and
SpO2,
SpO2.
and then FiO2,
Okay, what is the FiO2 at right now?
21.
Right. What happens if, let's have fun with this. Let's, if I turn my FiO2 to 21%, but don't turn it to oxygen, what's going to happen?
Then it's just gonna pull room air.
And it's going to scream because it has to do something it's not capable of doing.
What, 21 or 22%?
Either,
Oh, it should be a pull at 21.
right? But not.
Correct.
Right.
100 if I don't put it in oxygen. Everybody work with that?
Yes.
So let's make it fair. Everybody wants to know how to troubleshoot alarms, so let's go there first. Touch the white button so you can black the cursor.
Adjust it.
Let's go to
and then-
50%.
and then-
Can you guys do that on the computer?
FiO2, 50%.
And then
Touch
the
turn,
check
green
mark?
check confirm. Yep. If we know it's going to get angry. Perfect. Read the screen, guys.
Operation switch to compressor,
Plug it in.
plug it in,
So first-
check O2 supply,
Maybe it's empty.
check or replace your regulator,
Maybe you broke it.
set it to 21%,
Why it alarms, it tells you, guys. And get
connect low flow monitor, last contact service center.
So next, go back to 21%.
So while you're troubleshooting everything else, if you go to 21, you'll shut it up.
And green check confirm, and within one breath, the machine shuts up.
So I noticed that the alarm didn't go off until it tried to do the breath.
Yeah, it takes one breath. It takes one correct breath. Another example of this is if it disconnects from the patient, what's the patient, when the machine going to say? Thank you. Right? What's it say?
Patient disconnects,
Yeah.
as opposed to low,
And how do I fix it?
plug them back in.
And to your point, one breath, I need a full breath.
So you don't have to sit here and punch silence buttons and,
Just fix the problem when it goes away.
Preach it, my friend.
I like that.
Yeah.
dude, if you want on camera.
I gotta be able to see. 'cause
It's
I know
gonna
you-
take you a little
you
bit.
fucker
You
the
got
red X.
You can, the red X is the alarm shut up button.
Okay.
Yeah, but if I pop this green one off, what's it gonna say?
The green one's disconnected.
O2, patient disconnect,
How do you fix it?
plug it back in.
We're done.
Hold on, though. Leave that off for a second. All right, so I hit that and I silence it, but it leaves the screen up, okay.
Yeah.
So
How long will it keep it from screaming?
30 seconds.
So when you automatically fix
See it right there, how much time you
it
have.
automatically.
Oh, okay.
like this, that.
Hmm.
The alarm silence, 13 seconds.
We'll go.
You don't even have to do anything. Perfect.
Yeah.
That's easy.
So read your patient, not your monitor. Everybody on board with that? Let's keep
It's
going.
beef bad, shock them. What? Wow.
Next one, PIP and PEEP are on the same line, right? What is the positive end expiratory pressure set at right now?
It's hollowed at 30,
Right.
Peeps
PEEP's at 5?
peeps at 5.
What's your EPAP at? 5, it's the same thing,
Right.
all right? And look at the graph on the next to it. What's the graph say you're at?
5 to 30.
5 to 30, look at that, right?
So what's the?
Oh, 5.
That's, volume title,
Yeah, and again, we don't know why it's not tidal volume, but it's.
whatever, I just.
Correct, yes.
Just reading it as
So
the same.
is your tidal volume
Uh,
hollow?
yeah.
Tidal volume is solid, 'cause that's what this is giving
Volume
it.
times solid. Right, 450, and you can adjust it.
I just changed it down. Oh,
And hit nothing.
oh, so
They do it.
yeah. I
So if I want my pressure, what's my pressure at right now?
30,
Is that high or low?
a little high.
Yeah, it's right on high,
It's
but
on the
it's
high
high, yeah.
mark.
If you want to get it down, how do you get it down?
Well, I just changed the tidal volume and it dropped it to 26 automatically.
You're a step ahead. Yeah, change your volume. They're married.
Clear eyes.
Forget flow.
No.
Forget
So be able to lengthen.
Forget flow, go home.
soft or slow. Better way to do this. Ramp. Right.
Isn't Flo an
You're right,
aunt, isn't
right.
Flo an aunt that visits once a month? Ow! Fucker, I was just asking, I got a fucked up family, I don't know these things.
So.
You wanna see my aunt, she's crazy as shit.
I just hit the button next
I can't
to it,
believe I
but
was
want
just
something
assaulted.
that use that.
No, it's hard, I'd rather have it out.
So now let's have a little bit of fun, and we're gonna take this to the next step. Inhalation phase, let's learn inhalation, exhalation phase. Positive and expiratory pressure, peak inspiratory pressure. Positive and expiratory pressure. So what is your peak at right now?
Peep,
Peep, peep,
peep is 5.
Okay, take your peak to 9, please. And what's gonna happen to this lung?
Gonna stay
Hold on, I gotta get, I have to push the button 3 times.
nine,
Alright, so peep's now at 9.
Stay further open.
Yeah,
and
and let's intubate without a peep valve.
you're still at 30.
Debate without a peep valve,
Empty
Yeah.
entirely.
Yeah? And my pressure goes to?
0.
Excellent.
You have collapsed lungs.
So let's go back to, let's get one breath, right? What is what's the respiratory rate at?
12, it's set at 12, but it's reading 13,
What's your
hollowed
patient
out.
breathing at?
13,
13. What's the half-life of rocuronium?
half the transport.
Right?
Standish,
So what's the vent sending?
Now it's 12.
What's the vent sending?
Then set it
sending 12,
it's
And
12.
what's the patient breathing at?
12.
Right now, 13.
14,
Patient over-breathing the vent, breath by breath.
waking up,
What's the alarm set up? So if you look right next to the numbers, the alarm should be
8 and 25.
25. Did the alarm go off yet?
No,
Is he over-breathing the vent?
yeah,
Do I need a paramedic?
no.
Needs to be on my radar. Right, not yet. Don't wait for the alarm. Right, you with me? You can see the problem first, get ahead of it.
So what you're saying is the guy starting to wake up.
Yeah.
So you guys need to just push your fucking drives. Is that what I'm following?
You are.
Yeah, so I
You guys are muted. Can you unmute?
Three.
1 to 3.0.
Okay, and why is it alarm?
Is that better?
Airway pressure high. What did you do to it?
Pressure exceeds the limit.
Drop your peak back down to 5, please.
Peep back to 5.
How are we been breath
Yeah, it's saying our,
It says high peak
PIP
setting.
is,
High PIP setting.
Okay, so now. in
yeah, it
front-
was hitting our PIP at 35 with
In
the PIP
front
at
of the
9.
word mode, M-O-D-E is T-I, time of ventilation.
In
Right?
front of mode,
M-O-D-E
Yeah.
in front of the M is T-I. What is your T-I at?
1.25.
That's our factory preset, 1.2. Unless, did you change the rate? All right, that's 1.25, is the factory preset.
It fixed itself.
Perfect, nice.
Just with the
So
wires.
if I need a longer E time, to your point, or I time, I can change 2 parameters. What are the 2 parameters I can change? Or respiratory rate, right? So what's the rate at?
12.
Change that to 15, please.
And it drops to 1.0.
It does the math for you. What patients need to exhale longer?
Bronchospasm.
Yeah, so what's the I&E ratio at right
Airway
now?
pressure's high. PIP's 36.
Why is the airway pressure high? Because my I time's too short. Give me a point. Right?
Because the eye time is, the eye time is too short.
Down to
Correct,
compensate for that.
correct.
How do we change the eye time?
How do you change the I time? Ask that question again.
That would be,
You
Go down the-
narrow that, so like instead of 1 to 3.
So let's play this game. You come to the emerge. What's your I time at right now?
1 to 2.
one,
What's it at right now?
no, one,
It's, the I time is 1.0.
1.0 now?
Yeah?
Okay, you go to the emergency room and the
What
respiratory
was that?
terrorist
What-
tells you they
what-
want an I time of 1.5. Please make that happen.
Change the rate.
Or
hold on.
Yeah.
And above.
the rate or.
No?
Yeah.
You can't
Oh,
change
you
it
gotta
directly,
hold
you
that
have to
button.
change the rate or the,
I&E ratio.
I&E ratio. You can't change the eye time itself.
So what do I,
So one,
all right, so I gotta bring it down. So if we're looking for I time of 1.5,
Yeah,
then I bring that down. It won't let me. Gives me 1.48 or 1.54,
all right.
which gives me a 1 to 1.6,
it gives you,
and it took it back.
Or drop, what's your I&E ratio at?
Hang on a minute. My IE ratios, it went back to 1.3. It wouldn't accept my time. So if I go back, if I drop the IE so I can get a 1.54, it
accept
gives
it.
me I hit accept. It gives me 1 to 1.6.
Fabulous. That's close enough, right? All of that to say, it won't let you over stretch the numbers. If you need 10 breaths per 1 minute, there's some I&E ratios you can't do. And to your point, yes, it will do I&E ratio, reverse.
So I changed this from 12 to 15. It went batshit crazy because of pressures. I need to change my IDE time.
Let's think about this in a minute. Everybody inhale slowly. Right. Now let's change your I in E time, your I time shorter. Make your I time shorter. Everybody inhale. Can you feel the increase of pressure?
Yeah,
So we shorten our I time, we'll increase pressures. You can't get away with it without it. Is that what you were talking about a minute ago?
Yeah.
Okay, cool. We're on the same page.
So let's say we've got this head injured patient. Let's not even get crazy yet with like a DKA, but let's say I had a TBI and we need to get him down to 30, right? And so we increase that rate to, 24, just because he's at 50 right now, let's say.
Sure.
And that's going to, at that point, I need to also start to think about changing my IDE times.
It does it for you automatically.
It didn't.
It did?
It just alarmed.
Well, your IDE time won't change, but your.
My inspiratory time did.
inspiratory, but
If the ratio will change because the ratio is based on the inspiratory time.
you're still at 1 point,
So make your ratio
Okay.
1 to 2.
okay, so
So if you.
my
Still
ID is
saying-
1 to 2.
Yeah, my IE is 1 to 2, and it's still reading high pressure because my PIP's 38. I can make that shut up,
Drop
but-
your PIP down. Drop your PIP down. How do you get your peak inspiratory pressure lower?
Lower tidal.
Yeah. Then 5 other ways to get your peak inspiratory pressure.
Lower right.
Thank you.
It's still,
Bronchodilators, magnesium, albuterol, patient positioning, right? Don't forget to treat your patient also, please.
Repeat that again.
Magnesium, bronchodilators.
We're trying to reduce the what?
Pressure.
Pressure.
Right.
Come down all
What's that?
I'm all the way down to 370 on the tidal volume, and it's still alarming at 36, 37.
Which was also a small test.
Oh, yeah, let's have a little bit of fun with this.
I just shut it up, but it's still. But if I increase my breaths per minute to 24, it's being counterproductive by dropping my tidal volume, because I drop my tidal volume, I'm also going to drop the amount of exhaled CO2.
Right, and
That's a-
the amount of oxygen going in.
Right. This is,
But if you double your respiratory rate, as long as you haven't had to have your tidal volume, you're still increasing your minute volume and blowing off more CO2.
But we're getting
right,
out of
but
it.
then it was giving us all these,
All of that to say,
alarms.
did you guys see what I did to make it a little green?
Yep.
What did I do?
You expanded it.
I traded my patient.
Bronchodilator.
Right. Did you follow that? All right. Now,
So was that just a tension setting? Is that all that was? So if you're continuously getting alarms like that, that's what you should do?
yeah,
Just expand that thing?
I'll treat your patient.
Well, treat the patient.
right, but if my patient is,
Listen, I don't know, that's why I'm asking.
But
You
it-
bastards.
so I'm looking at,
You know, you want to start talking.
I'm just a driver.
Yeah,
so I'm looking at this TBI kid,
On your lungs.
17 years old, no bronchospasm,
Turn it off real quick so it's looking here. This is a good question.
no bronchospasm. Turn it off, you said? The fuck's the off button?
The dial on the
Oh,
right.
thank you.
See, this is what we're learning.
So, this was a patient in Exeter, right? 17-year-old skateboarder, bam, down on his head. Combative, we RSI him. And you can watch, you watch him start to herniate,
Yeah.
right? So we want to get, like I just did with this, I wanted to get his CO2 down to say 30, 31, 32,
Use
right?
respiratory rate to do that.
The kid's got no bronchospasm going on. He's got no history of that. And that's what I was looking at just now, like, well,
We outgrow events quickly. So then we need some 1%. Saline, you need mannitol. Right?
right, but so I get that, but we don't have that in the field, right? So if I'm trying to blow off some CO2, like just now, and I took it to 24 to start, just let's drop it from 50 to 35 and then back off and slowly do that last 5, for example. And it's giving me all these alarms, and you were saying, well, you've got to either drop tidal volume or make that volume bigger. That volume shouldn't change on this kid, no matter what I do to him.
Let's go down this pathway. And it's a good question. Everybody on board with that? We're driving down the road. In this place, we're using TBI, traumatic brain injury, which is what we ship out all the time. That's our bread and butter, right? What's the doctor's name? We'd roll into the accident and the doctor would lock the door, like, don't bring him in here. And he was joking, right? He let me in there, but like, no, we don't need neuro at the accident. They all got shipped out. A bit of wisdom is if the patient takes 3 days to get in this problem, they need at least 3 days to get out.
Right.
So if you get some trending in the right direction, call it good. If your end-tidal CO2 is at 70, and you got your end-tidal CO2 at 60 or 65, call it a win. We're more with that. That's why they're going to somewhere else, right?
Right, but
So-
I mean, that might be your obtunded respiratory patient,
Yeah,
and that makes sense.
you
But with
for
this-
your acute trauma.
Acute traumatic TBI.
you
you
might
know.
not be able to fix it. You might not get to 0.
Well, I'm not looking, certainly not looking for 0, but what I guess what I'm asking is with this vent, with what we just saw, I mean, granted, so what did you have that screwed down to for like a volume?
I'm not going to answer
I'm gonna fucking stab you
And they're gonna-
right in the nutsack, okay?
So I was out in Pennsylvania doing this, and a lady looked at me and said, "I'm gonna stab you." And everyone, like, he's the Zoll guy. I'm like, "Go, this is how we break. We're done here."
So apparently my twin works in Ohio and it's a female.
She wanted to marry me. She's like, "You're cute, take him away."
Yeah, she's not my twin then.
Yeah. Let's talk about this. Who likes dope?
Wow, which dope?
Yes.
Data on previously engaged targets?
Yes.
Or, I can't remember the stupid mnemonic.
You mean
Displacement,
dislodgement,
obstruction.
obstruction?
Yeah.
I was thinking more of a
Right, moving on.
dope.
He's thinking.
I was thinking about
more
tryptamaines.
Yeah.
Where do
There's
you
so
go?
many fucking
Matt right
things
now?
could be dope.
I know there's a lot, you know,
Hmm?
I
was
would
gonna
dope.
use his firefighter knowledge while I was here, but he left. If I'm fighting fire and I get an attack line going in the house, and New Center 9 WMUR drives over my attack line and pokes a hole in it. At the pump, where does the pressure go?
Down.
Because all the pressure's coming out.
Depends on how hard I hit them.
Right. Before you do that, right, down. Anytime there's a hole in the circuit, you get something that says patient disconnect, PEEP leak, low volume, low tidal volume, patient not connected. Those are the types of alarms you will get. So let's start at the patient. Always read your patient first, then your monitor. At the tip of the ET tube, what holes can you have that should not be there?
Bronchial disruption.
Yeah, so if the new doctor decides to intubate with a stylet sticking out 1 inch and he pokes a hole in, right hole. If they drink uric acid, a hole. If they drink Clorox bleach, yes, they're committed, but you're gonna get a hole. If they have a TE fistula, if you're intubating in Maine and you grab the balloon off that one snaggle tooth, you can't ever inflate your balloon, and you have a cuff leak.
I did that in New Hampshire once.
Spontaneous.
Thank you. We're going there. What if the patient seizes and bites the ET tooth? PEEP leak, low pressure alarm, patient disconnect alarm, means a hole.
Hang on a second. We gotta see if one of us needs to go.
Some of the oxygen trucks.
That sounds like a Joel problem.
They're over there.
Well, you have
Meet
Wayne-
them for what?
you-
Is Wayne on the truck now?
Wayne and JT. down there.
Joel and JT.
Joel and JT.
They got an truck over there.
Yeah, but, meet them for what? Is it,
For
an
lunch?
anxiety problem?
You're
Or
too-
is it like they just fucking blew them away?
You're too hopeful.
No, I'm not, dude. I don't want to do shit. I'm nothing. I love this, but I don't ever want to use it. All right.
D.
Hey, Kevin, I'm glad nothing changed.
Hey, you should send them, if they're going, you should send him with them on that call.
You know if he wants to. Or they shouldn't be going.
T, where are you going?
What's this call? Oh, okay. I couldn't tell. I can't tell the tones. Uh-oh, another message action. Kevin, you're fired.
But Kevin, I remember way back when in the EMT course, I told you I hadn't seen the water boy, and you said, I'm going to stab you. You got it. Oh, yes.
That is a quote?
That's a quote.
Godless communist, absolutely.
D, dislodge. Anytime we have a dislodge, there will be a low pressure. Treat your patient first because those are things that will kill them. Would that work with that? If it pops off the top, if you have a hole in the circuit, if they bite through it.
Those are your A's and your B's.
Back to, I use big fancy words. Oh.
What's that?
Sounds like the truck can handle that.
Yeah, I don't know what their update is, because God forbid they tell you why the fuck you're going. God,
I
hate
thought I
you
just
so
said
much.
that.
They suck.
All right.
If I'm fighting fire and at an attack line going in the house, and WMUR, New Center 9, drives over my attack line and keeks it. At the pump, where's the pressure? To the truck. Thank you. Let's talk at the patient. The ET tube should be about 1 centimeter north of the cranium, maybe 2 centimeters, right, on X-ray. It never is, but that's what they say in the textbook. What occlusions or clots can you have there?
Right against the
Right up against the carina, against the anatomy. If there's a swelling or burned airway, it can swell around that. You
Or
gotta cut
mucus.
the- Or mucus plug. How do you fix a mucus plug?
Suction.
Deep trach suction. By the way, there's an EMT basic skill in the skidding management. Oh, by the way, don't ask how I know, just accept that if they have an inline suction and you suction properly, clear that, please remember to pull all the way out. Just, yeah, that's
We
good.
need those. We should have those in our airway bags for all intubated patients.
If the patient seizes against a tube, if they have a head injury, it coughs it, bucks against, but they're not paralyzed well against the tube.
Fight block,
Okay, so let's talk about what are you guys using for commercial tube devices?
the blue.
The Tom's tube.
With the white screw on the side that you can crank down and kink the ET tube and get a high pressure alarm?
Yeah.
All right, all right, cool.
So I've heard.
Yeah, high pressure alarm, right?
Or at the top, when they, let go of the bag.
Yeah, right. On that note, yes, you can put inline neb, your inline suction, your inline bong, whatever you want. Yes, you can put a filter here. I like the filter here on exhalation. I know it's a COVID hose. That's why I like it here. But it's absolutely appropriate to put it here too. That just makes my stack heavy.
Bench things, more the tube, yada, yada.
Will that, putting it in line, mess with your pressure readings any?
Yes. So this vent does not measure dead space. So to answer that question appropriately, if I have inline suction, inline bong, inline neb, I have to increase my dead space. I have to increase my volume. If I increase my volume, I have to increase my pressure. Everybody on board with that? So yes, you should. The correct way to say this is each piece, your inline neb has a dead space reading on it. Your inline suction has a dead, you should take all of those things and add it to your tidal volume. I never have once done that on adult patients. Right, because most adults have enough room to compensate, but don't tell my boss I ever said that. That's the appropriate way to do it. Fair?
I think of it like a syringe from this far. That's roughly a 10 cc syringe.
Like it? Yeah, it's just a trick. I like that a lot. Exhaust port. Everybody on board with that? I will make fun of myself. I put the head of the bed at 30 degrees and hang this off the back, and I would take the extra tube and put it under the pillow so it's out of the way, right? Please don't do that. Don't cover up the exhaust port. I've also seen people put this between their legs, put the 9-foot strap through the handle. It's a slick idea. And then they run the tube up and then they drop a blanket over everything and cover the exhaust port. Please don't do that. It's a bad idea. Fair? D,
Just
dislike.
another filter.
If it's bent over, if it's kinked, if you step on it, if you stand on it. What's the half-life of albuterol?
5 minutes.
Yeah, because that's a repeat dose. Again, that's a good rule, right? If I'm 5 minutes into the trip and I get a high pressure alarm, albuterol. Everybody on board with that? Halfway to the hospital for a paralytic is a high pressure alarm. Bronchospasms, high pressure alarms. Bad BLS airways, if we have extension and flexation of the neck, it will kick the ET tube and cause a high pressure alarm. Some systems use C collars, not for spinal cord injuries, but for extension and flexation. Everybody on board with that? Excellent. P, any question? Oh, the kinks on the top. P, D, dislodge, low pressure. O, obstruction, high pressure alarm. P, this is a trick question. This is an absolute 100% set up question. P, pneumothoraces, is it a high pressure or a low pressure alarm?
Depending on, where you are in the process, I think.
Immediately a low pressure, then
Yeah.
high pressure.
God, it's a pleasure. Remember I started out with saying some of the best in the movie? I look good when I do this. It's like, wow, you're so smart. It's a pleasure to be here, guys.
It's okay. They'll have tracheal deviation.
Yeah.
Take that right away, right?
Right off the
Right,
bat.
right. So if you go to the local hospital and the team shows you an x-ray, a flat film, and says, look, no tension pneumothoraces. Don't believe that.
No tension.
Yeah, okay, I heard that. Take your stethoscope and bury it in the armpit and have them put their arm down. You can hear the team saying, just go, just take them, just go. No, I can isolate that one lung. And then bury the other pit and then take some time, like take a moment and listen and know that response. So if you're driving down the road and their sats start to tank, their entitled CO2 goes up, their pain response goes, they're a little uncomfortable, they're grumpy, maybe a flail, maybe not. In the presence of a mechanism for injury for pneumothoraces, when you're high pressure ventilated, high pressure, right? I don't care what tool you're using, demand valve, I don't care. When we switch from negative pressure to positive pressure ventilation, that 1 or 2% pneumothoraces might become a 15% or 20% pneumothorax. How do you fix a pneumo?
Needle.
Think or chest or skull, whatever you do, right? If you get to the other side and you fix that, you look like a human. If you get to the other side and scream with a high pressure alarm with a 60% pneumothorax.
And dope and, lever-fed running because their pressure's tanked and you haven't recognized it a pneumo.
You do not look like a hero anymore.
Dear John, I quit. Your truck's in the parking
face
lot.
of chest trunk, drawer, flail chest, nunchucks to the chest, whatever you do, it has to be high on your radar. Fair?
And a flat plate chest film, a lot of times, it's below the lung and they don't see, because when you sit up,
You need a KUB.
it's gravity and shit.
So you need a
He's also selling us an ultrasound.
Listen, we got one in Belmont and they fucking kick ass, I'm just saying.
Where you at? Front
We
of
got
the
that
EMT, right?
We got that butterfly, man, I think
I
it's
do
great.
that.
Zoll doesn't sell ultrasound.
The new Philips monitor.
Yeah, but that's an old school ultrasound. Like we can do that. Butterfly's better than that thing.
Butterflies are sweet.
Yeah.
It is.
The Philips. Have you played with the Philips ultrasound one?
Their brand new one?
Yeah, it's crappy.
Oh,
Yeah.
Butterflies is nice just because it has usually 3 different programs in one.
Yeah, and it's small and concise and slick.
Plug it right into your iPad.
Yeah. So DOP. Please turn the vent on for me, please. Thank you.
Boy, we
If
got
I,
a lot
by the way, look in
Tools
the
and
upper right
toys
hand
to
corner.
play with, guys.
Does it say adult in the upper right hand corner?
not yet. Upper
Yeah.
left-hand corner.
Upper left. Then hit the
Your
green
right,
check.
my left.
Hit the green check.
Okay.
How long did that take?
It took longer for you to tell me.
They're inventing. Use this
Back
back
up.
on.
And it's just going from the previous setting?
No,
No.
there's one that says
Or,
previous
or is
setting.
this just going right to the default?
The default.
This is
How-
going to the default.
How do we change that?
Let me show you one thing at a
So that
time.
goes into it. That's
Look,
what
if I disconnect it, what's the vent gonna say?
Patient
it-
disconnect.
Hey, so this-
Why isn't it alarming though?
Because I get 2 minutes of silence to set up.
Oh, okay. Yeah.
What's
okay.
it say?
Patient disconnect, check
Okay.
connection, check
There you go.
circuit,
If I cover it up, what's it gonna say?
high pressure.
Fabulous.
Oh, well,
Great,
first
right.
it says great.
Give it a breath.
There we go. It's VTAC,
Now it's
Yeah.
gonna have airway pressure.
airway pressure
There
high,
you go. That's my circuit check, guys.
circuit.
Shock his lungs.
Right?
That's it.
Right on board with that? That's how you do a circuit check. You should do it with your inline stack, your internal CO2, your neb, your bong, whatever you put in line. You should do it.
Yeah, it's for the devil.
Have you ever heard of a bong?
Yeah,
This tally gets better.
I was on a medical call one time.
Yeah, that's right.
So DOPE, dislodge, obstruction, pneumothorax, equipment failure. If I do my circuit check before I roll on the patient, I know it's not the vent,
Or the circuit.
right?
Right.
DOPE. So if you switch to a bag valve mask, again, if you can't tell, I'm a big fan of many tools. I need 100 tools to accomplish one task, right? But if you get to DOPE and this is alarming and you switch to a BVM, fine, use another tool. But what you essentially did was you ignored your patient. Those are not vent broken alarms, especially since I checked my circuit. I know it's not the vent. That is now a patient care alarm. And if you switch to BVM, you still own the responsibility to paramedic. You own the head to toe to figure out why it was alarming.
We made the thing shut up.
None of us are actually good enough to do compliance with a BVM.
Ah, so say that again. Say it again.
Said none of us are good enough to do compliance with a BVM. The
When
ones
he
in our
says,
truck.
Especially because the guy venting for us is the lowest common denominator on that
started
truck.
in the very
You
beginning,
fucking don't forget it either.
if we squeeze too hard,
Yeah.
what happens? Let's talk about compliance versus resistance.
Blood pressure,
But
barotrauma.
barotrauma, all that, and we're used to doing that. We squeeze so hard, their toes get bigger, right? And then we learn maybe that's not a good idea. Maybe a pediatric BVM, or just squeeze in the back of the BVM. There's a whole bunch of others. Like some, yeah, I saw one guy. You know when the BVM comes in the bag and you pull it out, they left it in the bag. They left it in the half shape. It's a cool little street trick, you know.
Why don't we just get rid of the adult bags and just use pediatric?
Because if we can't increase volume, we can't increase pressure. And some patients need bigger pressures.
And some of those PD bags are only like 500 total, so you've got to get
But you're not wrong.
everything out.
Londonderry Fire uses speeds on adult
Right.
press. Yeah, it's not a bad idea at all.
They do.
So the manual breath button, it is also a plateau pressure. Other machines called inspiratory holder and eye hold. Manual plaque pressures should be less than 30. I'll explain to you what that is in a minute. It causes an inspiratory hold, gives me a mean airway pressure, and what's the number in the upper left-hand corner?
11.7,
Is that less than 30?
yeah.
We're ventilating well and not causing lung damage. We get above 30, we know we're causing damage. Now, the unfortunate part about that, it's called a plateau pressure or a P plaque or an inspiratory hold or an I hold. A lot of the patients we transport out already have been where they are for too long with the COVID, with the black lung disease, and so their plateau pressures are screaming high. But that's where we are.
Perfect. So what is the plateau number? What's the range it needs to be in?
Less than 30.
That's it, just less than
Yeah.
30? Okay.
So let's say this COVID pneumonia dude is running 35, 40. Is, in my mind, that says to me this is not one we should be taking.
I don't write New Hampshire State protocol. I don't know the answer to that. You should follow local health control.
Well, no, I'm just,
But that's not gonna be a
But-
healthy patient.
but, yeah, no, right, I mean, that, you know, I mean, we can turn any critical care down and say, no, I'm not comfortable with it.
And the state of New Hampshire allows that, right?
Right. So I'm trying to think this out loud for all of us.
But that would.
At what number would you say with this P-plat, would you say, you know, fuck this, let's have the Dartmouth crew come get it by ground?
Let's do it the other way. Name 5 ways to drop a pressure, plateau pressure.
Drugs,
Drugs, 1.
tidal volume,
2.
rate,
Right?
A decompression?
Decompression. Sit them up. Lay them on their stomach. Get a good BLS airway.
lay them on their stomach.
Yeah. Prone, although they're not recommending it for transport just because it's shorter times and it's very difficult to
Left
kind of.
lateral recumbent, right?
Yeah.
So once you've done all of those things, it's never immature to answer your question. It's never about one number. Are they have a good plateau pressure?
Right, but I mean,
Yeah.
but if everything else, I guess what I mean is,
You can use that.
everything else looks good, and you say, well, there's no, it's that ARDS that they have from this.
Yeah.
And this patient,
And let's say that we know that this is the ARDS that they have,
right,
or the black lung disease, or silica. Do not milk your baby's butt with baby powder anymore. Please stop doing that. Yeah,
Bad stuff.
right, right.
he's fine. Right.
Sure about that?
Well,
I work with the bastard.
I don't know, that's the question.
We might need to have a
And
conversation.
this is where we are, and he's
He's
been there
breathing
for a
funny.
few hours, and we just have to go, and his pressure's fine. His end-tidal CO2 is elevated, but this is where we are. It's a predictable, unchanging, unstable patient, right? I don't know. So, switch to BBM, fine, you still own the assessment. DOE, questions about that?
So do we need to start this thing up and test it for an extended period of time before we take a transport or anything like
Now,
that?
how long does it take to do a tube check? Sort of check.
One breath.
Right, because don't we do that now? Like 15 minutes or 20 minutes?
Well, that's, we still put it on the patient for 20 minutes while we transport.
So this is the same thing then?
no,
So
this
we
is
say to do
simply-
a circuit check just to make sure it's holding.
this is just
right
going-
as it should.
18 seconds, we can have it all set up and running on the
So
patient.
before you
Then
apply to your
it starts
patient, you do a
15
circuit
minutes.
check, And then you put it on the patient with our vent, and then you have 15 minutes.
To see how the patient reacts.
Okay, so
Right.
so we're still
Intervention.
doing that, that doesn't trigger.
because all vents are a little different.
I'm just,
Mr.
that's
Wright,
what I'm asking.
Don't let a single man in this room confuse you or woman. What you're saying is correct.
Okay. Just checking.
911 is different, you don't have to just go.
See, this is why I just stay on the fucking 911 truck, it's easier for me.
Why,
So-
you could be using this on that one truck?
Nope.
There you are.
Let's have a little bit of fun.
fun.
Let's, and we still are gonna do some CPAP stuff, right? I said 4 hours, and we're not 4 hours in yet. I still have an hour left. I hope you're learning a lot so far.
Yeah, I know I am.
I need a volunteer.
I volunteered last time and somebody else this time.
Okay, you did. Way to man up. Yeah, sure. What we're going to do is we're going to have you leave the room, and we're gonna mess with the vent and break things and have you come back and troubleshoot.
The vendor, the patient.
Yes. Right? Which is why I didn't want to tell you how I changed the title, right? All right,
What's that?
Where is it?
Hey, how, like,
Yeah.
now that it's running and you wanna go from adult preset bullshit
What do y'all want to drink?
to BiPAP or
Yeah.
CPAP?
I go with Joe's.
All right,
Manhattan.
Okay, and that's at this pizza joint over here?
Mr. Jennings, help me, my patient's dying, help me.
Say that again.
He's dying, get in here, get him out, transfer this patient out, go over, get out of my ear. Help me, Mr. Jennings.
We need to receive.
And that's- You're ignoring it. Pizza joint right here.
Yes.
Patient disconnected. So we need to receive the pizza.
We start with something easy, we're gonna kind of accelerate from here. Right, patient disconnected, saw that right away, and it did help that we were a little bit pumped up. But yeah, good. Next, any other volunteer?
Sure, I'll volunteer.
All right. Well,
Everybody,
Not that I get right, then I'm on.
2012 is just a simulation. It did. The world ended. It's over. Everything's fine.
It all went down.
You know, Justin.
This is actually just how.
You know, Justin.
We just didn't notice.
No.
We didn't notice the transition.
Brian Hughes and Hopkinton, they're all the same.
Right, I left New York like a year and a half ago.
All the same. So I'm gonna make a conclusion. With the conclusion, what are we gonna get?
High pressure.
So what do you expect him to
You're
do?
a little bit more of a highlighter done.
What is he gonna do when it comes to
Certification.
Hopefully.
chest rise? No chest rise. No chest rise.
So it's behind the.
See? All right. Help me, my patient's dying, help me.
The door here.
Who's gonna open the door?
He didn't say C, he said PSI.
The name.
I move right over, help me. He's dying.
High pressure. Are you breathing?
You tell me everything you need to see is great.
Yeah.
Up there.
Dude.
There you go.
What's it to me?
Ooh, nice. He said high pressure, he saw occlusion, he looked at his patient first. Let's
That's
talk
not
about
my
what
face.
different things can cause a high pressure alarm at your patient's side.
Obstruction.
Start working from the patient back. is what I-
Boom, and he's, right? Obstructions,
Stretcher wheel.
stretcher wheel,
Yeah.
elbow,
Just when you put the stretcher in and hook it in, very easy, things get,
Mm,
you know, initially,
That's
right
why,
off the bat.
that's why we carry extra circuits on the ambulance. Each put a hole in
what with that? I need another volunteer.
Well,
Let's do
well,
it.
how come you
Mr.
didn't
Jenks
put
is
it,
out.
how come you didn't put an extra?
Oh, wait.
urine bag?
it.
Kevin, take a picture of the screen, please.
Take a picture of the screen.
Yeah.
oh, God, this is bad.
That's if you bag or use
He's
it.
gonna give you a difficult one.
Yeah.
We take out our other one. Lots gonna change.
Picture of the screen. Whoa, wrong direction, there we go. I was like, oh, that's
Hey,
me.
Kevin, you might want to carry an extra urine bag
Yeah.
on the ambulance. I popped one the other day. So I put the patient on in, what's this, oh. I had to go back into the hospital, said, I need a new bag.
Now, what he asked me about is what did I turn on the patient before? If you look here, I can change the diameter that will cause bronchospasm.
Oh, pretty cool.
So we are going to change some settings, but not enough to make it alarm. So his pressure's gonna go up, but not above the alarm. So it's heading towards alarm. This patient has a return of bronchospasm. You follow that?
Bronchodilator.
Yeah, so, and the tubing's gonna look fine, right?
And it's not gonna be a long.
Gee, Kevin, this is actually a nice teaching education tool.
Are we go missing?
Are we giving test lines? Is that-
Or like the
do we
test
have
lines.
any test lines?
Not like that, we don't. We do have a, we do have a test.
All right, Kevin,
Where is it?
It's in the tip box.
Sit down, man. Don't.
Is that obstructed?
Almost. Help me, my patient's dying. Good, everybody on board with that? What did he target?
Patient.
Yeah, good, well done.
Good breath per minute.
Can you stand up so we see that, or is that,
You can, it doesn't matter what position you're back to. You're back, I'm saying.
Let's stand the monitor up there, I mean.
But then I can't see it.
You can't
So
see
what
it?
changed, Mr. Jennings?
Patient's breathing, airway's intact. FiO2's at what we can have, my pressures are good, my volume's good.
What
my
was your
rates
pressure
are-
at before?
Well, my peak's at 5. 5 to 15. So my rate went from 5. PIP at 15, it's now at 29. But it's still within my alarm limits. Patients waking up maybe?
What else?
Volume is the same.
Or what else? Patients waking up, run through that last.
So waking up, seizing,
Waking up.
agitated.
Are his pressures screaming high yet?
No, but he's trending high.
Did his pressure double?
Yes.
Is there something going on?
Okay.
Yes. Please be aggressive to see. Remember when I talked about flail chest, breath by breath, moment by moment, you can tell. And the alarm should not surprise you. Now, he stepped out and came back, but if he's watching the patient, he would go from 15 to
You
16.
know the machine is not a problem.
And one of the things I do with my partners in back, regardless of what level, is I say like, hey, keep an eye on these numbers. A second set of eyes, you know. I do that with my CO2. I do that. If you see this, get my attention.
Right.
I'm busy doing shit.
And for the record, that's why I like the sound of this vent. It sounds really good right now. Yeah, and now, how's the vent sound, right? Or even just a little or a rate will change, the patient will cough against you.
Or if you lose oxygen.
How did you?
Yeah.
How did you change that pressure?
Should we
The
tell
size
him?
of the bag?
Should we tell him?
You can't change the size of the lungs, what can you change? What
Well, you
change?
can change the size of that one.
No, the patient.
Different size holes.
Right, yeah. So, yeah, okay.
Yeah. Somebody else want to take a turn, or should I take a
So
turn?
it could be bronchospasm too then.
Yeah.
That's what-
Expiratory V's for a magnesium drip. or-
Looking at my monitor, my CO2 should help tell me that waveform.
Right. I need one picture. Do not make any decision on one device ever. Everybody on board with that? Thank you. I'll step out. Tillis, you're next. You want to go tea?
Go T, go T.
Grab a donut on the way. It makes the waiting easier.
Everybody on board with that? Yeah. All right, tea. I'm sorry.
This is bullshit.
We didn't say eat, we said inhale.
I
All
call
right,
it.
help me. My patient's dying. Help me, tea. Is T doing the right things? On the right stuff right now? Yeah.
Yeah, I think you're right, so that one should, your loose end
Holy
should pop
shit.
in. That.
You're helping him like that?
Teamwork makes the dream work.
Yeah, right? You just gotta understand, we want this.
I'm like, what the hell's going on? Okay, no.
T, well done.
Thank you. Thank you.
Shit shouldn't dangle.
Things can change, right?
That happens with age, though.
So, and they,
That's why
the
toilet
filter
seat
that
height
we're,
is so
The
important.
HEPA filter for COVID is supposed to be, and just put it, we can put it in line before it comes off the tube, but really just put it right here, and that's, and it gets it out of the way. And so we don't have something heavy flopping around.
That's my opinion. Whole bunch of other people have different opinions, but yes, I agree with you 100%.
yeah.
You let me eat half a donut with goddamn pizza on the way?
Yes.
You son of a bitch, you know I don't have that much gastric volume.
I'm gonna do this.
You know what, you go take a dump and you'll be all set.
Yeah. So
I'm
no
gonna
one needs to
step
go to
out.
the bathroom before he makes room to go.
I'll take my turn. I will step out. You guys mess with the vent. I'll come in and take my turn, right?
Excellent.
Can we take the battery out of it?
Every time. Every time.
You got big enough a hammer, you can.
Yeah.
Yeah, where's the thing you said not to twist?
Yeah, what, don't twist this.
Comes in, there's just a knife on the screen.
Yeah.
Yeah, fix it.
Fireman hand clip.
I sneezed.
Oh.
Is it pediatrics or?
You kind of roll it.
Yes.
No, you pick that up quick.
I had a partner set up the vent like that once and confused the hell out of us for like 10 minutes.
Oh, you got the smaller one. Very good.
Okay, kayak boy, come on in.
All right, from the door, I'm gonna roll in. I'm gonna target my feet. Right now, is that chest rising?
Yes,
No, that chest is not rising good enough.
you didn't qualify. You said, is it
And
rising?
you said yes, you're not wrong. But do I have a good enough chest rise?
Don't know.
No.
I'll stop. I don't care. Shut the vent off. Go back to the patient, get rid of this thing. Get back this patient, please.
Sure.
Perfect.
Okay, what's your next step though? Right?
Lung sounds. What I got for some lung sounds?
I don't know, bag it.
Are they equal? Rise?
Yes,
Yeah? Do you have expiratory, inspiratory wheeze?
no, lung sounds are good.
Okay. Into the volume, into the bases, I got good chest rise?
Yeah.
Fabulous.
Good tidal volume.
Good. I don't have to troubleshoot this? Oh. Will you guys get me a new circuit, please? I'm not gonna spend all day long troubleshooting the circuit. I'm busy. Give me a new circuit. If my
Cool.
patient is good, I get rid of the machine. Follow that? Turn it back on. Green check. Hook it up to my patient.
Earlier.
Can I give her receipts too? 12, 450, rated 10. What's going on with my patient? I'll set up my vent settings appropriate for this patient. That's what it says.
It took you a little longer to figure out those tubes were crossing than it did for me.
Right.
But,
Who's your patient?
why is it not picking up the hole in the tube that I put in it?
It's self-sealed.
Mr. Jenks? Could compensates for it nicely. It absolutely 100% compensates for it.
That's pretty cool though, right there. So even though there's a hole in it, it'll work fine.
Yeah, don't care.
Wow.
That's dope.
That's
No, yeah. Can the hole get too big? Sure. Yeah, that's a smaller hole, don't care. Means nothing to me.
So would it just increase?
The pip changed from 15 with my thumb off it, negative suction. I dropped to 14.
There you go.
Now it's up to 16 with my finger over it. So
So that's 2 points. 2 points.
yeah.
It's nothing.
That's not bad at all.
Damn it.
Wow.
To the point, now let's do this the next way.
Now
You
Kevin
expect
really
a high
needs that.
pressure alarm, right?
Now I want to.
If you kink it, with the hole, you want a low pressure alarm. But, if I kink it, doesn't care. Get close to the hole.
Oh,
To get serious about it, you gotta kink it. Right, everybody on board?
So the stretcher wheel.
Yeah, there you go, now we hear it, right?
Okay.
Yeah. But just a little hole, that's nothing.
Hmm.
I like that.
Yeah.
Oh, yeah. No, it's, wow.
So I have a random question about where we're putting this in.
Hold on.
Why?
Keep that on.
Ooh, I like that.
All right.
Should we eat?
I'm gonna
so they can
pause this
watch
for
us
lunch
and make
and
them part
then
of
we'll
it?
come back.
You're gonna pause it.
I was like, I got chest rise. Why are my pressures here?
Just so you guys know online, we're gonna break for lunch and then come back in like a half an
I'm
hour.
not getting any pressure. And I'm like, just walk back on.
Thank you.
And
Yeah.
kept trying and retrying, changing settings.
Thanks.